मेरे इसमें ना my MacBook somehow is not compatible, then everything comes ghost. We have tried it multiple times with Sai, but it doesn't happen.
अच्छा अच्छा अच्छा
तो अब नया MacBook अगर चेयरमैन साइंटिफिक खरीदेगा तो फिर लेंगे.
यहाँ जनरल सेक्रेटरी बैठी हुई है, तुम चेयरमैन साइंटिफिक को मानते हो? तिजोरी वाली.
I am happy with your background, Prashant. It's looking very good. It's okay.
प्रशांत मैं दे देता हूँ, बदले में क्या दोगे?
ये महिपाल सर ये सही बोला आपने.
सर CFS का बैनर पीछे लगा दूंगा.
बिल्कुल बिजनेसमैन स्टाइल में मैं देता हूँ.
महिपाल सर ने तीर मारा है.
ये तो बड़ा सस्ता सौदा है.
सुनील जी, I think 6:31. Sunil ji, are you going live?
Yeah, live.
Partha sir, I'm not able to get my virtual background right. I think it's all hazy, so I'll just delete it.
Yes,
I'll go without it, please, sir.
Absolutely, sir.
Sorry.
Are we live? Sunil?
Yeah, we are live.
Okay. So, good evening, everyone, and welcome to the North Zone Talent Search. And this is the final zone of the Talent Search program. And now we go over to the finals. So the finalists are all there from all the zones, and now it's the turn for the North Zone. So welcome North Zone and the young, bright participants and the young judges as well. So welcome everyone to this theme of the talent show in the North Zone competition. So talent is talent, and it is well said that at the end of my life, if I can stand up to God and say that I have used every bit of talent that you gave me, then my job is done, my life on earth fulfilled. So let's go ahead and into the talent search, and with an introduction of our chairpersons and our judges. The AIOS Governing Council, as usual, has been ever supportive, and I owe, and the scientific committee team owes everything to the Governing Council, who always give us the great support. Our members, Dr. Amit Porwal, Dr. Fairuz, Dr. Jatinder Singh Bhalla, Dr. Krishna Prasad Kudlu, Dr. Parikshit, Dr. Somshila Murthy, and Dr. Sonu Goel. Thanks to them for doing all the hard work in this talent search program. Thank you, sir, for being the chairperson, giving your valuable time. Dr. Mahipal, sir, President AIOS, Chairman Scientific Committee, IRSI, Chairman and Managing Director, Center for Sight Group of Eye Hospitals. Sir, welcome. Dr. Lalit Verma, our Vice President AIOS and Senior Consultant at Center for Sight. Sir would be joining us very soon, and we await him. Professor Namrata Sharma, Secretary AIOS, Professor of Ophthalmology, Cataract, Cornea, and Refractive Services, Center Services at AIMS, New Delhi. Welcome, Dr. Namrata. We have our two vibrant moderators today, Dr. Amit Porwal and Dr. Sonu Goel, who is going to carry us through this program, minute by minute, hour by hour, and we finish just in about 2 hours' time. So that is for Amit and Sonu to take the cue. Let me introduce to you the judges of the day. Dr. B.C. Lavingya, Madam is Chief Surgeon, the Cornea Foundation Eye Hospital, Ahmedabad, known for her volumes of work over decades in cornea. Madam, warm welcome to you. Dr. D. Ramamurthy, Chairman, Eye Foundation Group of Hospitals and past President of AIOS. Welcome, sir. And you've been a judge for so many programs, and I'm sure we are looking forward to not only your questions, but also your inputs to this program of ours. Thank you, sir, for joining us. Dr. Guru Prasad Ayachet, Director, Clinical Services and Head of Vitreoretinal Services at M.M. Joshi Institute, Hubli. Welcome, sir. Thank you for being with us today. Dr. Meena Chakravarti, Senior Consultant at Chakravarti Eye Care Center, Trivandrum, President of Kerala Society of Ophthalmic Surgeons. Welcome, Madam. Dr. Meena, thank you very much for being with us this evening. Dr. Santosh Honawar, Editor Journal, AIOS, Director, National Retinoblastoma Foundation, Department of Oculoplasty and Oncology and Ophthalmic and Facial Plastic Surgery, Center for Sight, Super Specialty Eye Hospital in Hyderabad. Santosh, known for his phenomenal work in the IGO, as well as His teaching capabilities are phenomenal. Thank you, Santosh, for being with us today. Dr. K.S. Kumar, Senior Vitreoretina Surgeon, Kumar Netralaya, Bangalore. Kumar, thank you. With all your innovations that you have done, you're going to judge these wonderful, bright minds on their innovations today. Dr. Prashant Bawankule, a dear friend, Senior Vitreoretina Surgeon and Managing Director, Sarakshi Netralaya, Pune, Sarakshi Netralaya, Nagpur. Sorry, Prashant. Possibly you'll have one in Pune as well. So thank you for being with us this evening and happy judging. So with this, I hand over the podium to Dr. Sonu Goel and Dr. Amit Porwal for the evening.
Thank you, Dr. Partha. And thank you.
Before
AIOS
that,
office.
we request Dr. Maipal sir
to
give a brief comment and a warm welcome to everyone.
Thank you very much, Dr. Partha, and thank you, Scientific Committee, Partha as chairman and the members of the Scientific Committee for organizing this wonderful program. I've had the opportunity to participate in almost all these zones, and I think each zone has done better than the other. The important thing is that what we see in the youngsters is that they have the thought process, the innovation, and they have the willpower and the determination to take forward what they believe or what they dream of. And as they say that the future belongs to those who believe in the beauty of their dreams. I think that's the most important thing that they have to do. And apart from the basic scientific knowledge that they have, the ingredients are also sometimes what is known as a gut feel. And I think sometimes you believe in everything. That means each and every cell of your body believes in a gut feel that this is the way it has to be, has to go. And that is how innovation is born. And whenever we are looking at innovation, I think failures are the stepping stones for success. And that is what makes a person different from the others. You may keep on failing, but I think with each failure, you need to learn something. That is the most important. That is the kind of spirit that I am seeing in these youngsters who are coming out with these new innovations and new thought processes. And I would wish to, right in the beginning, congratulate all of them for having reached this particular stage. We look forward to your great presentations. And I think it is a learning experience for all of us, whether the people who are senior citizens or who are youngsters or who are middle-aged. I think there's a lot of learning that we get from all these presentations. Whoever wins at the end and goes to the final, that will be decided by the judges. And I know that the judges will have a tough time. But kudos to all of you for coming forward and keep up the spirit and the zeal to do something new and take Indian ophthalmology to the forefront. Thank you very much. And thank you for having me here, Partha, and the other members of the scientific committee, Amit and Sonu, and other members, Dr. Bhalla, etc. Thank you.
Thank you, sir, very much. And Dr. Namrata, a few words from you.
Thank you, Partha. I think, like always, it's a pleasure to be here at the talent search programs. And like I said, although it's, moving like a pyramid, so we are going from the various state societies are sending in their nominees, and then it is going into the zones, and then from out of all these zones also, we will have the first top 3 in the finals. But I think it is not about the peak of the pyramid. It is more about the bottom of the pyramid, and the fact that the entire talent of India is here at the bottom of the pyramid is more important. So it really doesn't make a difference who gets the prize. It makes a difference who are a part of it and who will continue to innovate and continue to evolve. So that's a continuum process, and that's a dynamic process that will keep happening. So Partha, I think we should begin the program now. And thank you for doing this, and thank you all the scientific committee members who are such a vibrant lot, and they have been organizing webinars after webinars with great themes. So I think we can begin now.
Thank you, Namrata. Over to Sonu and to Amit.
Thank you, Dr. Partha. Thank you, Dr. Mahipal and Dr. Namrata. So we are going to start our talent show. So before we begin, the rules which has already been told to all our speakers, The judges have received the evaluation Google forms. So after each talk, you fill the form and go to the next. And for the speakers, mind you, 4 minutes is your time. You will get one signal at the end of 3 minutes and the last signal at the end of 4 minutes. So if you continue beyond 4 minutes, then you lose marks that you have taken into account. And before we begin, I would request everybody to show their faces so that we can take a screenshot before we start the program. So I request everybody to show their faces so that we good memory of a North Zone talent search. Thank you. Thank you all. Prashant, Sunil, Kalpana, everybody. Yeah. So now we begin our talent show, the North Zone talent show. The first speaker is Dr. Abhinav Dhami, and the lead judges for him is Dr. Ramurthy and Dr. Prashant Bavankule. And to introduce Dr. Dhami, we have our own moderator, Dr. Sonu. He is going to introduce Dr. Dhami. And Sonu, over to you.
Yeah. So Dr. Abhinav Dhami is working as a consultant cataract retina uvea at the Dhami Eye Hospital, a very young, dynamic, second-generation consultant from the Dhami group, I should say. He completed his fellowship in vitro retina from Shankar Netralaya, Chennai in 2017, published 28 PubMed index articles, and won the best paper at the DOS. So Abhinav, all to you, all the best. You can start sharing your screen now.
Thank you, sir. Thank you, everyone. And okay.
Abhinav, just before you speak and the judges begin their marking, so I'd like to reinstate that all judges are to mark all the contestants. Therefore, and the lead judges will open up the discussion with their questions, but any judge can take up a question after the lead judges. Thank you.
Thank you, sir. Thank you for the opportunity. So I have...
Hi, I am Dr. Abhinav Dhami, Consultant Cataract and Retina Services from Dhami Eye Care Hospital. Let's discuss today the role of OCT in management of white mature cataract and posterior polar cataract. A safe continuous curvilinear capsular hexis or CCC still poses a challenge in mature and intumescent cataracts. The incidence of incomplete capsular hexis associated with white cataract surgery is around 28.3%. What we have in our surgical armamentarium: Repan blue, puncture of the anterior capsule, two-stage capsular hexis, insulin needle-assisted capsular perforation and fluid removal, femto laser-assisted capsular hexis. Now we use OCT to find the fluid spaces in mature cataracts. The image on left shows no subcapsular fluid pockets, while the images on the right side show definitive fluid pockets in the subcapsular space. We performed wide-to-wide angle scan on AIOS-SC. We used a wide-to-wide angle scan on Cirrus HD OCT for analyzing the presence or absence of fluid pockets in mature or intumescent cataracts. They can generate a wide field, speckle-reduced raster scan of the anterior chamber at a depth of 2.9 mm. Type 1. In the presence of lenticular pocket spaces, we perforate the anterior capsule using a 30G needle directly through the limbus and perform active suction of fluid from the mid-equator region till we can appreciate the nucleus. Type 2. If no fluid is noted on AIOS-SC in a white cataract, then capsular hexis was performed using Utrata forceps directly. Demography of study groups highlights the capsular success in either group with the number of capsular complications. We were able to achieve better success rate with 30-gauge needle-assisted fluid removal in white cataracts. Does it make any difference? Surgical success rate gets greatly enhanced when the operating surgeon knows about the presence of fluid pockets in making a complete capsular hexis. So we come to the conclusion that the technique allows a surgeon in better management of subcapsular fluid removal, preoperatively using a 30G needle, thus minimizing the chances of developing radial tear. And the AIOS-SC acts as a guide in determining the presence or absence of fluid for a stable and easy removal of subcapsular fluid, decreasing the chances of capsular tears. Now, let's discuss the role of OCT in posterior polar cataracts. The biggest dilemma in posterior polar cataract is the predictability of developing a posterior capsule rent. What literature states: intact. If the capsular margin was traced below the posterior polar cataract without any defect or discontinuity. Dehiscent. If the capsular margin could not be traced under the posterior polar cataract or if there was any defect or discontinuity. What we are working on is evaluating the role of anterior segment optical coherence tomography AIOS-SC using SOCT Copernicus Revo in the IOL Master 700 for predicting posterior capsular integrity in posterior polar cataract. Results. Demography of the patients was as follows. Proposed classification on octuple revo in the IOL Master 700. We noticed 3 types of PPC. Continuous, where the posterior capsule was seen beyond the PPC. Abrupt, where the posterior capsule cannot be placed around the PPC. And dehiscent. Herein the posterior capsule defect is noted with contents in the patellar fossa. Results comparison. We observed the predisposition for developing posterior capsular rent is greater for type 3 PPC. The octuple revo gives a better prediction in understanding the capsula as compared to IOL Master 700. So we come to a conclusion that PPC is diagnosed clinically and with AIOS-SC in 3 types. Type 1 and Type 2 have a high negative predictive value, 100 AIOS-SC. If the PC is noted to be intact on AIOS-SC preoperatively, likely not to rupture during surgery. It allows the surgeon to have a better informed preoperative counseling within explaining the surgical success rate. PPC can occur in 3 different types: visible continuous PC, localized absence of PC, total deficit with protrusion of contents in the patellar fossa. AIOS-SC plays an important role in preoperative workup in white mature cataracts and posterior polar cataracts, and can help in providing better surgical outcomes. Thank you.
Thank you. Thank you, Abhinav, for that wonderful presentation. I think it's a very interesting presentation, and a lot of work has been done by Dr. Tyal, Dr. Ramamurthy, Dr. Mahipal. So, Amit, if we can have the lead judges, Dr. Ramamurthy and Dr. Prashant Bavankule.
Yeah, so we invite Dr. Ramamurthy to initiate the discussion. Dr. Ramamurthy.
Yeah, nice presentation, Abhinav. I mean, interesting. I've heard this before. Basically, there are 2 aspects that you're dealing with. One is of white mature cataracts, another is posterior polar cataract. Yes, as far as white mature cataract is concerned, of course, if we have this tool, it's of great use. But even a normal good slit lamp examination and a AC depth measurement, would it give you a fair idea as to whether it's a intumescent cataract or it's a white cataract, which can be handled in the conventional manner? And number 2 is that, you have spoken about this posterior capsular defect, and you say that there have been instances when there is a posterior capsular defect and cortical matter in the AC has been, in the patellar fossa has been identified.
Yes, sir.
During surgery, you have found that there's no PC rent. I mean, how do you... there's no
only in 2 cases, the PC defect, the PC rent happened. In 2 cases, it didn't happen. So when we went back and we looked at the OCT scans, actually the PC rent, when it happens, it's in those cases where the anterior hyaloid is not intact. And if the anterior hyaloid is intact, then even the type 3 cases don't give away. So I think that's what we've been working on now, to localize if the anterior hyaloid can be visualized in all such cases. Hyaloid plays a very important part.
So you mean to say the anterior segment OCT, if the anterior hyaloid is intact, which will be the case in most cases, confuses it with the intact posterior capsule?
No, sir. The intact capsule is visualized very easily on it. It's only when the defect is noted. So if a defect is noted, we tell the patient, there's a very high chance of rupture. But sometimes when we can visualize the anterior hyaloid face, it is not visible in all the cases. If the polar cataract is very thick, then the anterior hyaloid is not visualized. But if the PP cataract is not so thick in its measurement, then we can see the anterior hyaloid, and those cases don't rupture at all, actually.
And how does it change your management of these cases, the way you handle them, whether you see a rent or as you proceed with the case? Obviously, in all PPC cases, I forewarn my patients that things may not go according to plan. There might be a change in the type of intraocular lens that we use, and not doing hydrodelineation, other things. Anyway, you handle it differently based on the information that you get.
I think the type 1 and type 2, where we know that the capsule is intact, even while keeping with all the precautions that we have been told or been taught, I think it's very easy. We can go ahead with all the kind of IOLs. Even we have we can plan for a multifocal IOL. You know that the capsule is going to be intact, but the only problem is this capsule is actually fragile. So the one needs to take in caution that even if you have a type 1 or type 2 PPC, the capsule is still fragile. If you actually exert too much pressure on the capsule, it does go away. In the type 3 cataract, we know it's going to rupture, we actually plan for a 3-piece IOL or a single-piece IOL. We don't give the option of a foldable lens or something of that. So we say, okay, you want to put a 3-piece IOL because there's a very high chance, and we keep a VR backup on the manual. That's usually me. Then I'm always on the side. We have the machine ready, and we make sure that if it falls, we're going to do a vitrectomy on the table itself.
I think I quite agree with you. I just have to add that, I look at the AIOS-SC that's available in the with the laser cataract surgery systems, and in case I find that kind of a dehiscence, in that case I make sure that there's no rotation of the nucleus, and I do not do any kind of hydrodissection or viscodissection. Otherwise, I go ahead and do that after debulking the nucleus. That helps me to rotate the nucleus. And of course, you take a little more. But the fact that you have also differentiated between two particular instruments, one is SSOCT based, another is ray tracing. I would have expected that the ray tracing technology would be ahead, but according to your findings, it's the
So actually, it works very well in the type 1 and type 2. In the type 3, sometimes you're not able to see the defect. And sometimes what happened was there was a lot of cases where we thought it was actually a type 2. And we used to confirm the same finding on the AIOS-SC. The AIOS-SC, actually, the most of the times we actually assume that a defect is always going to be in the central space. The AIOS-SC allows us to go through horizontally and vertically. The defect is not always central. Sometimes we found the defect was right at the edge of the PPC, and sometimes the defect was right in the parasagittal region. So to assume that it's always going to be central was a mistake on our part also. We realized later on that we were able to localize the defect in the parasagittal or even in the edges. So with the only care I think we had to take was while doing the debulking of the epinuclear cortex, we do it very slowly now. So that we just make a cabbage form in the central chamber, and then we just slowly peel it off so that we don't rip it off in one go.
I think the take-home message you want to say is that in spite of all this, whatever caution you exercise with the PPC cataracts, you continue to do it irrespective of what you see on the scans. But of course, this is an additional adjunct that you have.
Yes,
Thank you. Well done.
Thank you. Prashant, over to you.
Yeah, I have nothing much to add about it, basically. It's well-established things and very well-established, rather, put it across.
Thank you. So, any other judges have any question for Abhinav?
Yeah, I have one.
Yeah.
Did you have any instance where the 30 gauge needle got clogged? Because 30 gauge needle is too small a bore, and I would expect that the needle might get clogged. Did you have any instance?
I think the only thing that has to be taken care of when we are putting the needle in the subcapsular space, most people tend to put the bevel up. So we have to make sure the bevel is down. So if the bevel is up, actually it gets clogged by the capsule itself. So if you keep the bevel down, then it's actually much more easier.
So
Anybody else? Yeah. So over to you.
Thank you, Abhinav, for that wonderful presentation. And now we have the second in row, and I would request my dynamic co-moderator, Dr. Amit Porwal, to introduce Dr. Amar Pujari, and the lead judges for him would be Dr. D. Ramamurthy and Dr. Prashant Bavankule. All to you, Amit.
Thank you, Sonu. So Dr. Amar Pujari is currently working as an assistant professor at RP Center, AIIMS. He has authored 124 PubMed Index publications. To his awards and recognition, he's got the AIOS Scientific Vision Award in 2020. He was an invited speaker for Japanese Glaucoma Society in 2020 annual meet on smartphone innovations in glaucoma. He has also won the AC Agarwal Trophy in 2019 indoors. Also, the Professor Pradeep Sharma International Hero in Spossy in 2019. So over to you, Amar. Please share your screen and. Yeah.
Sir, are my slides visible?
Yeah, your screen share is visible. Now your slides also are visible.
Yes, sir. Thank you. Good evening, everyone. My presentation is on the categorization or classification of post-polar cataracts using anti-segment OCT. I do not have any financial interest in any of the instruments discussed below. So why post-polar cataracts are important? Because as Dhami has said and Dr. Ramamurthy sir has said, because these cataract patients are going to have deficient or weaker capsule inherently. So that's why we need to find out which cases have deficient capsule and which cases have intact capsule. So in literature, as sir has said, Ramamurthy sir, even though there are clinically definite described signs to identify the deficient capsule, but sometimes the opacity is going to be dense. So in that case, in those conditions, people or the researchers are going for a cross-sectional imaging modality like anti-segment OCT. Since 2014, from China, Hong Kong, and other Indian studies have stated that AIOS-SC is a viable tool or alternate tool to identify the deficient capsule, including recent Maipal sir's femtosecond catalyst anti-segment OCT integrated imaging system. But the thing is, all these imaging modalities were spectral domain. So we need to move on to soft source OCT, which is going to have longer wavelength and which can image from cornea to the posterior capsule in one shot. So with these limitations in mind, we observed initially 26 cases. In that one, we learned that retrospectively, we need to define the deficient capsule. If I want to say with surety, we need to define the contour as well as the capsule. As we know, the posterior capsule is going to have a convex contour. In the left 4 images, you can see the contour has been lost at the apical portion. At the same time, if you see, there is a definite dearth or deficiency of capsule is there. So because of a deficiency of the capsule, you feel that there is a herniation of the cortical matter into the anterior vitreous. So we found this in 4 cases out of 26, and we term this as a conical sign, and we published in JCRS. However, this was a limited study. We wanted to study in a larger perspective. So that's why we included a CASIA 2 OCT, which is going to be a soft source anti-segment OCT. As you can see on the right side image, it can image from corneal surface to the posterior capsule in one shot. It gives like a UBM picture. Okay. In addition, the advantage of this machine is it can magnify up to 200 times. So you can quantify even the 4 micron, 5 micron size of the capsule. So that is the advantage of this one. So we included 101 eyes, which is the largest series in literature till now of post-polar cataract. So in that one, we identified 91 capsules as intact and 10 capsules are non-intact. So in that one, we categorize the deficient capsule into specific morphologies and generalized morphology. In specific one, first one was conical. Whatever the previously we described in 26, that we reaffirmed here. Here in the left bottom, left-sided image, you can see the red dots indicate the contour of the posterior capsule. Definitely, there is a ectatic posterior herniation of the cortical matter into the anterior vitreous. It looks like as if there is a nipple-shaped bulging is there. So that was observed in 2 eyes. Moth-eaten was second observation, where we are able to see, in contrast to conical swine, here the matter is not getting herniated into the anterior vitreous, but rather than the posterior opacity in capsule looks like as if somebody has taken a bite from that one. So it is going intralenticularly. So again, we are not able to see the capsule and the contour has been lost. Here it is into the anterior vitreous, here it is intralenticularly. In the third portion, on the right side image, you can see behind the opacity, sometimes the capsule is not going to be in continuum. It's going to have discordance on either side of the opacity. That we termed as a ectatic appearance. So in addition to these conditions, these patients had capsular rent intraoperatively. We saw that one, we compared that one. But in addition, again, patients were developing rent. What was the cause for that one? So we reassessed the 100 images, and we found that again there were 2 types of patterns were visible. In the left side image, you can see the opacity, posterior opacity, the circular discord opacity is snugly attached to the capsule. Okay, and there are no hypoechoic areas or there is no intervening spaces. But on the right side, you can see the opacity is attached to the capsule, but somehow there are hypoechoic or lucent areas in between. So that means that the opacity is loosely attached to the capsule. So on the left side image, when there are no hypoechoic areas, when you are taking out all the lens matter and we are just taking out the opacity, discord opacity, at that time we are going to put so much suction on that one. So probably it is going to give away or it's going to cause a partial tear in the capsule. So after that, we used to see a thin, flimsy capsule, where surgeon used to often say, when I took the opacity, I was not able to see the capsule, but somehow when I injected the tripod, even I was not able to see the vitreous. So that's why after removing this opacity, there was a thin, flimsy capsule. So that is again a risk factor for rupture. So we classify the post-polar cataracts in 101 eyes to conclude specific morphologies, which was around 10%. In that one, conical morphology, which is going to have 100% PCR rate. Moth-eaten, again, that is going to have 100% PCR rate. And ectatic appearance, which is going to have around 66%, because out of 3, only 2 patients were operated in our series. And in general morphologies of 91 patients, we are going to categorize them as with hypoechoic areas and without hypoechoic areas. When there are no hypoechoic areas between the opacity and capsule, there is around 15% chances of rent. In our series, 40 out of 6 eyes were had capsular rent. In other side, where there are hypoechoic areas, definite hypoechoic areas, so there will be easy separation because of percolation of the fluid when we are doing the phaco, initial phaco. So the capsular rent rate is less than 2%. This we published recently in JCRS journal. Thank you.
Thank you, Amar.
Yes,
for that wonderful presentation. So the lead judges, can you stop sharing the screen? Yes, Dr. D. Ramamurthy sir and Dr. Prashant.
Yeah, I think it's a great presentation and a nice follow-up on what Abhinav had presented. Could you tell me whether any differences between the 2 studies? You heard the other one also, or both of you concur with the findings?
Yes, sir. Sir, if you search the literature, what Dr. Dhami has said in type 3 when he was not able to see the capsule, that coincides with the Maipal sir's recent IGO publication where they have published that what lies beneath the opacity. So when you see these cases and the literature cases in JCR's all the 7-6 publications, what we are doing is ultimately we are identifying the capsule and the opacity. But spectral domain OCT are not able to identify the junction of the opacity and capsule clearly. So even some of the people have written correspondence or commentaries in JCRS journals where they have shown that we need to assess these images on image software or MATLAB software or on a soft source OCT, which is going to have a finer magnification, which is able to show the opacity and the capsular junction clearly. So probably what Dhami is saying, Dr. Dhami, is the third time where they are not able to see. When you see the configuration of those people's third category and Maypal search some of the images in IGO, it looks like as if the capsule is deficient and matter is getting herniated into the anterovitreous. So in general, some people have said it's a teardrop sign. We want to say there is a definite capsule dearth is, if it is there, then there is going to be some matter herniation in the anterovitreous. That we are going to call as a conical sign. And sometimes even Dr. Coker said moth-eaten appearance, he said it's going to be a fibrotic variant rather than moth-eaten appearance. So ultimately we need to identify in individual patient about what is the relation between the opacity and capsule after magnifying. If you are not able to see in a low signal scan, you can go on to images software or MATLAB software. You can enhance the intensity of the signal. Then you can comment about the opacity and capsular integrity.
You showed two types of classification. One is hyperechoic and hypoechoic. Another is that moth-eaten, conical. I mean, yes. Do they go hand in hand, or they are two distinct streams and you have to look for both? How do you interpret? How do you combine the two?
Yes, these are going to be different. So that's why we said specific morphologies where we can describe in some form of patterns like conical, moth-eaten, or rectatic, sir. And the second, with and without hypoechoic, they are going to have definite intact capsule, sir. As we saw in our previous images, here the capsule is not deficient, capsule is intact. But surgeon intraoperatively, they are going to feel differently. Some people are going to say, when I took the opacity, the capsule was very thin and flimsy. I was not confident whether to put IOL in the bag or in the cell cast. So that is a scenario when we introspected these images. What is the probable AIOS-SC finding that we can caution the surgeon in future? So in our center, whichever case comes to me. So in that case, I will do OCT, and if it is snugly attached to the capsule, I will say probably while removing the opacity, you might experience this kind of some kind of partial tear or thin flimsy capsule. Be cautious about that one. When there is a definite hypoechoic area. So
all these 101 eyes that you presented, they have been operated upon, and post-operatively, did they concur with the findings and what happened on the operation table?
Yes, sir. 101 eyes we operated. We correlated intraoperatively, sir.
So on OCT, I think all cases were done on intraop OCT microscope, and they were correlated on that.
Yes, ma'am. Some of the patients we did correlation intraoperatively using IOS-SC, ma'am. And we saw what is going to happen with hydrodynation, how the fluid wave is going to separate the cortical matter and the opacity, ma'am. What is the impact? In some cases, we saw there is a sudden giveaway of the opacity. There is a fracture of the opacity that has been accepted in IGO, ma'am.
Amar, have you correlated it with femto, the OCT on a flax machine?
No, sir. We didn't correlate with the femtosecond, sir. But I read your two articles in JCRS and IGO, sir.
That was absolutely 100%. It's basically we've not. Whenever I make it a procedure of choice as a femto as a procedure of choice, and 100% of the cases I am able to tell on the table whether I'll need to look at it and have a block and things like that in this particular case or not. So I have not had any false negativity as regards to that, but. We are also doing a study correlating the catalyst system as also the 700 as also the OCT pre-op and intra-op. I don't correlate it with the microscopic OCT, but that's ongoing, and there are cases which you miss out on the IOL Master 700 where you don't get that good an image as also on the OCT. But when you are looking at a three-dimensional OCT that you have on the plaques, that according to us is the best prognosticator for having a pre-existing rent or not.
Thank you, sir. Prashant, over you. Your comments, Prashant?
I think all people have already asked. It's not my cup of tea much.
Listen to all the answers. All questions are answered. No, I think it's a very good study, prospective study for one, multi-surgeon study for another one, which sometimes helps because, you know, all the surgeons are doing in different manner. And two is that it has an intra-op correlation. Each case has an intra-op correlation also. So that also helps. And femto, of course, sir, all our posterior polar cataract patients cannot afford femto.
No, that's fine. I'm just trying to say that
conventional in this. But yes, whenever we do femto, then in these cases, we get them down to the intraoppository microscope. We have to change floors from 6th floor, the patient comes to 5th floor, and then we do it.
So, Dr. Namrata, what I was trying to emphasize is that both these presentations by Dr. Dhami as also just now, so both of them are actually suggesting a more and more significant role, both Amar and Abhinav, that they are suggesting a significant role as also others. So we should all of us, whether we do have or do not have a femtolaser system, that's something different, but you have the OCT with an anterior attachment, and you have like those who have a swept source, you have the IOL Master 700, etc. Those things should be done pre-operatively to actually be able to prognosticate whether you are expecting a intra-op rent or not, because there is a very significant correlation. That is, I think both these studies have highlighted, and that needs to go down as a message now, that whenever you write a polar cataract, you should actually spend more time on it, even pre-operatively, to find out as to whether you are going to anticipate a complication, whether you should have a retina surgeon standby, or you should have something of a 3-piece lens for doing a scleral fixation, etc., etc. So those are the things that are getting highlighted over the last couple of years. And I think both these studies are excellent studies.
I think
we'll take a last comment from Dr. Guru Prasad.
Yeah, I just wanted to know whether age was taken into consideration, because I feel that the status of the vitreous, whether it is fluid vitreous or formed vitreous, is also a factor which determines whether the PC is going to give way, whatever may be the characteristics of the polar cataract. So I think an age-matched population should have been taken for this study, so that we could know whether the vitreous has any bearing on the number of PC rents or the occurrence of PC rents in these cases.
Okay. So, Sonu, finish this case?
Dr. Namrata was saying something, I think.
One thing, which says volumes about Indian ophthalmology. If you see all the papers on anterior segment OCT, on posterior polar, between the 3 groups that are sitting here already, I think we would have done, all the 3 groups from India have done the maximum amount of work. We don't have any other publication from anywhere else in the world except from here. So I think that says it all between, all the Indian ophthalmologists.
Okay, so we finish. Yes, Dr. Ramurthy.
Oh, just to cover up what Dr. Guru Prasad said, I think it is the age is important, and even Dhami was referring to the fact that the anterior hyaloid being intact also makes a difference. That's the reason some of those cases where he found some excrescences in the patella fossa, on the table he found that the posterior capsule appeared to be intact. Maybe that's one of the reasons, and very often maybe in a younger eye the posterior capsule and the anterior hyaloid is fused together.
Okay. So we finish this case and we go to our next case because we are running short of time. And the next case will be by Dr. Aniruddha Agarwal. And the lead judges for him is Dr. Guru Prasad and Dr. K.S. Kumar. And to introduce him, we have our Dynamic Scientific Committee member, Dr. Parikshit Gupte. He will be introducing Dr. Aniruddha. So, Dr. Parikshit.
Hi, thank you, Dr. Amit. Doctor seems to be a star right from the beginning. He's done his MBBS from GS State Medical College, that's considered the best in Maharashtra, followed by his master's in ophthalmology from PGI Chandigarh, and later a clinical research fellowship in Omaha, Nebraska. And he's received numerous awards, and he's more than 175 publications, which is mind-boggling at this age. And well, he's just started about 11 years ago as an undergraduate student, and now he's pursuing a PhD. So over to you, Dr. Agarwal. Best of luck.
So Aniruddha, over to you. Please share your screen.
Yes, thank you very much, sir. And are my slides visible?
No, not yet. You are just scaring. You have shared. Yeah, they are visible now.
Thank you. At the outset, I would like to thank the AIOS Scientific Committee, Chandigarh Ophthalmic Society for this privilege and honor. It's indeed a proud privilege for me to represent the city beautiful Chandigarh. And my topic today evening is redefining ocular disease using fundus imaging, what retinal imaging holds for us in 2021. My research is divided into 2 broad areas. One is differentiating and diagnosing, and second, quantification of retinal pathology. And I have 2 broad goals. One, is using simple imaging, whatever is available to most of us, as well as complex machines such as OCT and OCT angio to get answers in the clinic. My second goal is to establish collaborative research relationships globally. Moving on to my first area of interest, which is TB serpiginous like choroiditis. What we have done is in our clinics, we have used simple clinical observations and fundus imaging to grade lesions into 3 grades. And we observe that lesions which are of grade 3 opacity, they tend to progress and develop paradoxical worsening. This simple observation was recently published in American Journal of Ophthalmology. And after several attempts, we have now succeeded in developing an automated algorithm to identify choroiditis lesions on fundus imaging and infrared, and are now in the midst of developing a convoluted neural network for using artificial intelligence. We see patients of TB choroiditis day in and day out and image them using fluorescein angiography and ICG. And in 2017, we showed that OCT angio is very useful in showing that these patients have choriocapillaries flow deficit areas, which was published in Retina. And now in 2020, we have followed these patients and have shown that lesions which are very small on OCT angio tend to heal with minimal flow void. We have also shown that OCT angio can be used in the follow-up of these patients non-invasively, and you don't really need to depend upon invasive imaging such as ICG. And this was also published in Retina recently in 2020. Another area of interest is utilization of OCT in differentiating entities which are difficult, such as toxoplasmosis, viral retinitis, and ocular lymphoma. And we know that apart from lab tests, which are of paramount importance in establishing a diagnosis, features such as presence of cells, such stalagmite retinal deposits, and choroidal involvement favor diagnosis of entities such as toxoplasmosis. This was also published in British Journal of Ophthalmology recently in 2019. I will end with a very simple case. This is a male nurse who complained of decreased vision in the left eye. And if you see the OCT, it is so characteristic. You have vitreous cells, you have hyperreflective areas in the outer plexiform layer, and you have cysts. And this patient also had flow deficit on OCT angio. We have named this entity as dengue-induced inflammatory ischemic foveolitis and outer maculopathy. Since 2015, I've been a part of a number of imaging study groups. And what I've gained a lot of knowledge, and apart from that, I have gained a lot of friendship and collegiality, which I will cherish forever. And with this, once again, I would like to thank the AIOS for this opportunity. Thank you, and Jai Hind. Thank you.
Thank you, Aniruddha. So the lead judges, Dr. Guru Prasad and Dr. Kumar. So I invite Dr. Guru Prasad, sir, to initiate the discussion.
Amit, do you think Indian ophthalmology is growing bounds and leaps?
Everywhere Indian ophthalmologists are spread. You go to any international meet, we have our own delegation from AIOS going there. So I think Indian ophthalmology is doing a great work with stalwarts who are already there in this webinar. Thanks to Dr. Mahipal, Dr. Namrata, and all our Dr. Guru is there. MM Joshi has been gaining so many awards every year. So we have our own mentors who are helping and training their juniors to come up and present in international forums.
Blessed. Fantastic juniors.
I feel blessed to have leaders like this and mentors.
So, no doubt about it. No doubt about it. So Guru sir, over to you.
All to the judges.
Thank you, Amit, for those kind words. And thank you, Aniruddha, for that wonderful presentation. I think there's nothing much to add in this. You have been the pioneer of imaging in the country, along with the seniors under whom you have been mentored by. Just a few questions. I just want to know OCTA in an inflammation, how useful is it? Because the choroid as such will be, the appearance of the choroid will be smudged. The choroidal vessels will not be very well seen in a choroiditis. But how is OCTA really helpful in inflammation? Is it only during the recovery period, or is it during the active inflammatory stage?
So there are two aspects to use of OCTA, and I find that one is the active choroiditis. In the active stage, OCTA is very useful, and it exactly corresponds to ICG imaging. So if you do it at baseline, you can really follow up these patients of conditions such as VKH, TB choroiditis, multifocal choroiditis, PIC, and other entities solely on OCT angiography. And that's what we are doing routinely for a lot of our patients. The second aspect is detection of choroidal neovascularizations. And in conditions such as PIC or multifocal choroiditis, now even toxoplasmosis, we are seeing these abnormal vessels much earlier than development of fluid on OCT. So I think for these two areas, specifically OCT angio definitely has an edge over the other available imaging modalities.
Kumar, you want to say something? Kumar?
Dr. Kumar?
Am I audible?
Yeah, you're audible.
Am I audible?
Yeah, you're audible.
Yeah, excellent paper, Aniruddha. I think your studies will be of use as a form of reverse engineering. Once we have all the data from the various modalities of imaging, that kind of a reverse engineering may be of great help for those who rely heavily on their clinical skills. We are eagerly looking forward to the information from reverse engineering.
Yes, sir. What this actually helps is if you see some of the images, you can actually go back and revise your pathophysiology. So a lot of changes that you see on OCT, you go back and you're able to correlate with histopathology and understand disease process better. So for example, in VKH, we have come up with bacillary layer detachment. And now you go back into the histopathology and realize that this is something that happens in all of the post-mortem eyes. So I think it's very useful to correlate with the pathology.
Excellent paper.
Can I come back to the same question about OCTA and ICGA comparison? In the active stage, the ICGA would show hypocynescence or hypofluorescence or whatever you call it, and that means that there is ischemia in the active inflammatory stage. How does it show up on the OCTA? Does it show up as small caliber vessels, or does it show up as flow void, or does it show up as a good flow? What exactly does it show?
So in three entities, which are multifocal choroiditis, MPE, and TB choroiditis, which are practically 99% of the choroiditis we see, in the active stage on OCTA, it's a completely dark hyporeflective area.
Right.
And only when the lesions heal, you will start seeing underlying either medium-sized choroidal vessels or few choriocapillaries. So that begin to appear only once the disease starts to heal. Right. And mostly they'll appear in the center. So once the disease is really truly active, stage 1, you will see purely dark hypo area on OCTA.
Right. Okay.
Yes.
Any other question from anybody from the judges panel?
Just one last question. Aniruddha, do you think the retina or the vitreous together, they respond in limited number of ways to various inflammations or various insults, as we know? Do you think, now what is the basis? What do you think is the basis for these distinctive patterns that you're observing? Do you think the retina behaves differently to different etiologic agents?
Yes. So actually, if you read a paper on OCT in various infectious retinitis, we realize that the biological behavior of retinal tissue is very different if it's a viral infection compared to, let's say, an amoebic infection or toxoplasmosis. And I think this heavily depends upon the inciting organism. Of course, the final common pathway, which is scarring, gliosis, or necrosis, will remain the same. But the inciting pathogen will definitely cause a different response. And I think this has something to do with the specific nature of these cells in the retina, the neural tissue which is involved, the layers of retina which are involved. So I think they play the most important role. So viral retinitis is very different from toxoplasma, which will be a retinochoroiditis, and that correlates very well with the biological behavior of the organism.
So thank you, Aniruddha. So Sonu, over to you.
Amit, I just want to ask you whether you have been monitoring the time taken by the presenters. Because if it is exceeding, then you should let us know.
No. Yeah, that will know. Nobody has exceeded the time. There's an announcement being done.
Aniruddha finished very fast, actually, compared to the others. So I was wondering whether the
No. Everybody is doing within 4 minutes. There's one reminder being given at the end of 3 minutes, and this last reminder at the end of 4 minutes. Everybody has finished in time. So if they exceed, we will stop them. So you all will get the hint to cut down the marks. Don't worry, sir.
So thank you, Amit. I would now invite my colleague, Dr. J.S. Bhalla, and he'll be, I request him to introduce Dr. Kalpana Sharma. The lead judges for this talk would be Dr. Honawar and Dr. K.S. Kumar. Over to you, Dr. Bhalla.
Yeah. Thank you, Dr. Sonu. I think we have been having wonderful presentations, and it's really mind-boggling and very exciting presentations till now. Now it's my pleasure and privilege to introduce Dr. Kalpana Sharma. Dr. Kalpana Sharma is right now working as Assistant Professor of Ophthalmology at Indira Gandhi Medical College. She completed her MS Ophthalmology from the same place in Shimla, and she has numerous national and international publications. And she has also received awards at numerous fora during her presentations. Over to you, Dr. Kalpana. The stage is all yours, and all the best. Please start the screen sharing now.
Dr. Kalpana?
Kalpana, are you there?
She's there.
She
Dr.
was
Kalpana?
there.
Yeah, she was there.
I think so.
Yeah, you start sharing your screen, Dr. Kalpana.
My screen visible, sir?
Yeah. The lead judge for your presentation is Dr. Santosh Hornawar and Dr. K.S. Kumar. Sunil, you were saying something.
Should I share the screen?
Dr. Kalpana, you want us to share your screen?
So my screen.
Sunil, there is some problem with the network, I believe.
Yes, sir.
Now it's okay. Now it's better.
Kalpana, I'm sharing the screen. You can do the voiceover.
I think, yes, Sunil, you start sharing the screen. Dr. Kalpana?
Sunil, start the time once you start speaking, okay? Don't start the time when you start sharing the screen.
A very good evening, respected esteemed members. My topic is the effect of corona pandemic on ophthalmic services in tertiary care institute and its psychosocial impact. We all know that SARS coronavirus 2, it is the name of the virus that has engulfed the entire world, whereas the COVID-19, it is the name of the coronavirus disease. It has not only strained healthcare facilities, but it also has psychosocial repercussions. Now, the purpose of services in COVID era and its psychosocial impact. We retrospectively studied number of patients coming to OPD from March to August this year. This period was compared with corresponding months of previous year. The standard operating procedures for doctors and nurses of OT, OPD, and ward, they were laid as per AIOS guidelines. Now, when the lockdown was first announced on 23rd March, there were approximately 3 lakh cases around the world and 415 cases in India and only 2 cases in HP. From March to August, there were 4 lockdown phases and there were 3 unlock phases. So by the end of 31st August, that is on 1st September, there were 256 cases around the world, 36 lakh cases in India, and 6,000 cases in HP. Now, this is the graph showing number of patients, 1% reduction. Now, as we see, the number of 30% reduction was seen. Similarly, in diffraction, there was 93% reduction, and in OCT, there was 96% reduction in the month of April in comparison to the previous year. This is the table showing ophthalmic services from March to August. Now, coming to psychosocial impact. Now, when the lockdown was first imposed initially, people initially refused to accept the external reality because it was too threatening. So they adopted a denial phase of psychosocial defense. Subsequently, although there was limited spread of disease during the first lockdown, but it could not be contained. So it was further extended to 3rd May. And there were increases incidence of blaming certain groups and communities. So people adopted projection as psychosocial defense, in which they attributed other communities and groups the cause of their fear and anxiety. During the lockdown phase 3, there were increased incidences of violence on healthcare workers and lawmaking agencies. So people adopted this displacement as psychosocial defense, in which they shifted their aggressive behavior to less threatening targets. During the unlock phases, the people adopted suppression and acceptance as the psychosocial defense. In suppression, the people suppressed their anxiety to cope up with the external reality, and in acceptance, the people, they came out of their fear and anxiety despite increase in number of cases. So to conclude that the psychosocial impact of this pandemic is deep, and it should be addressed along with the pandemic control measures. And we should also strengthen our ophthalmic services, as we should be aware of the hidden burden of disease. And as we could see, and we are seeing a surge of cases presently and after the pandemic gets over. Thank you.
Thank you, Dr. Kalpana. So we have Dr. Hunawar with us.
Hi, Dr. Hunawar is there.
Good presentation, Kalpana. I think you have analyzed the OPD and surgical data of the corresponding period last year versus this year. And
Yes.
what I see is that although there was a slight decrease in March, in April and May, there was a deep decrease. And then it started picking up in August. Your surgical volume seems to be almost the same as what you saw last year, although your outpatient clinic volume has come down by 50%, which means that those who are actually needing surgery is coming, and there is more conversion despite lower numbers, and the surgical numbers are nearly come back to normal. That is all acceptable. But my concern is that how did you assess this psychological impact? Did you use any objective grading scale, or it was just your assumption that patients had this kind of a psychological impact?
So we related the various news from the media, and we categorized according to the Valiant classification, in which these theorists had classified the level 4 levels of psychosocial defense mechanism. That is, in the first level, there is denial in initial phase. Then in the second phase, there is projection, and there can be hypochondriasis and the passive aggressive behavior. In third level, we have displacement, which is aggressive form, and in the fourth phase, it is the emotionally stable people come to this stage, which is level 4 of the psychosocial defense, in which the person accepts. So acceptance and suppression is seen at level 4 of the psychosocial defense categorization.
But that's very generic. So you based your analysis on newspaper reports and whatever you have heard, not specifically by questioning those patients.
So we linked it with.
I'm not muted.
Because otherwise the questioning would be individualized, sir. So we only collected the.
So it is very generic. It's your classification of psychosocial impact is extremely generic, because you assume that patients did not come because of those psychological stages or the reactionary stages that these patients undergo. But on the contrary, in March and April, there was hardly any transportation available. That could be the reason why patients couldn't come.
Yes, sir. Yes, sir. A strict administration.
Multiple factors that may be responsible for non-attendance, and doctors also. When the initial lockdown was there, obviously clinics were all shut except for emergency services. So even if patients wanted to come, they couldn't have come. So there are multiple factors, and generalization of reactionary phases to your study without asking the patients why they did not come or why did they not choose to avail hospital facilities, I think is slight extrapolation of data beyond what we have found.
Yes,
would you agree with that?
Yes, sir, definitely, sir. Multiple causes of the drastic decrease in the number of patients coming in early phase of the lockdown.
Kumar, you have something to add?
No, I was just alluding to the same point. Maybe the impact of the psychosocial factors should have been done in concert with the Department of Psychiatry there, would have added, lended more credence to that aspect of the study.
Yes, sir. Definitely, sir.
But on a more personal thing, I would just like to share with the others here that we've had several patients who had other issues also, like such as depression, etc. I've at least had 2 instances where the patient had something very serious as a retinal detachment and chose not to come, and both of them were blinded in one eye, and the explanation they gave was, I have the other eye, sir, so I thought, let me allow one eye to go that way. So it has had really very profound effects in a small segment of people.
Any other questions from any of the judges? So I think, Amit, thank you, Kalpana, for that wonderful presentation, and thank you, judges. Thank you, Dr. Hunawar and Dr. Kumar. Amit, we can proceed on to the next presentation. All to you,
So
Amit.
Next presentation is by Dr. Mohammad Ibrahim Asif. And to introduce him, we have a dynamic scientific committee member, Dr. Feiruz, and the lead judges for Dr. Asif is Dr. Lavingya and Dr. Ramamurthy. So over to you, Feiruz, to introduce Dr. Asif.
Thank you, Dr. Amit, and good evening to everyone once again. So it has been wonderful so far with excellent presentation. And then we go on to the next with Dr. Mohammad Ibrahim Asif. Welcome to you and all the very best for your presentation. So to introduce Dr. Mohammad Ibrahim, he has completed his MBBS from JIPMER and he has completed his MD Ophthalmology from RP Center, AIMS, New Delhi. And currently he's a senior residency in cornea, cataract and refractive surgeries at RP Center. And he has done enormous work in academics and presentations and papers and research. So one of them he's going to showcase today, and I think probably it's the best of Asif's work. Over to you, Asif, and all the very best.
Thank you, ma'am. And I'll share my screen.
The person you are speaking with.
Asif, your screen has not yet come.
Just a minute, sir. So is it fine?
Yeah, now it is visible. Now you can go ahead with the presentation.
Yes, sir. Thank you, sir.
A 30-year-old gentleman had come to our clinic with poor vision in both eyes for the last 10 years. Visual acuity was perception of light in both eyes, and on slit lamp examination, both eyes revealed total leukomatous corneal opacity with band-shaped keratopathy. B-scan ultrasonogram revealed posterior dislocated nucleus in both eyes, and right eye temporary keratoplasty with pars plana vitrectomy and phaco-fragmentation with optical penetrating keratoplasty was planned, as right eye was the better eye with PR accurate. The patient was taken under general anesthesia. 3 standard 25-gauge pars plana ports were inserted. We can see the gush of fluid from the port, which was attributed to the liquefied vitreous. The port was checked and infusion started. The supratemporal and supranasal ports were then placed. The diameter of the cornea was measured using Castro-Veggio calipers and the center was marked. A 7.5 mm disposable corneal graphine was then used to cut the host tissue. An MVR entry was then made at the host tissue and at the limbus. Host tissue was cut using curved Vanna scissors. Viscoelastic was injected intermittently to stabilize the globe. The temporary keratoprosthesis was fixed over the cornea using 4 Weichel sutures. Anterior vitrectomy is being done. 4 vitrectomy is then being carried out. Triamcinolone acetonide is being injected for tagging the vitreous and inducing PVD. We are able to visualize a pale disc with sclerosed vessels and chorioretinal degeneration. We can also see that the vitreous is degenerated with very few vitreous strands. The hardness of the Brunison cataract was assessed and retrieval of the nucleus was attempted by bringing it to the anterior chamber using the cutter. One of the Weichel sutures was cut to provide space for the nucleus to come out. However, the lens dropped back into the vitreous cavity. Now an MVR is used to impale the nucleus and it was brought to the anterior chamber. Further, 2 Weichel sutures were cut and lens delivered to the anterior chamber. The keratoprosthesis was removed. An optical grade donor tissue of 8.5 mm was used for the penetrating keratoplasty. Superior 10-0 nylon suture was put to stabilize the cornea, followed by the other. After passing another 4 sutures, we went in again to remove remaining cortical matter that did not come out along with the nucleus. And the pars plana ports were removed and massaged to prevent air leak. the remaining nylon sutures were put, and after completion of 16 sutures, the sutures were buried and the donor tissue was tucked in at the graft close junction.
Thank you, Dr. Asif. So the lead judges for your presentation is Dr. Lavingya and Dr. K.S. Kumar. Sorry, Dr. Ramamurthy. So over to you, Dr. Bhati.
Asif, you have a good presentation.
Thank you, ma'am.
I wanted to know that you said the diagnosis is band keratopathy.
No, ma'am. The diagnosis was CHED. It was a 30-year-old male, and he had CHED, and which had associated band-shaped keratopathy in that patient.
Associated.
Yes, ma'am.
Any advantage of putting this prosthesis?
Ma'am, the advantage actually in this patient there was a nucleus drop also, so we have to do an associated vitreoretinal surgery in a corneal opacity patient. So we used a temporary K-Pro, which was very useful, and it was like doing it over a normal cornea, ma'am.
Is it possible to fix a slant precision lens in this patient?
Ma'am?
If they have fixed a slant precision lens also, it will let the patient effect, no?
Yeah, ma'am. Because the other eye we are not planning to operate because there was poor response of in the VER in the other eye. So since it is only one eye, we are going to operate to make the patient ambulatory. So we gave FAK glasses in the post-operative period.
And what was the post-operative vision?
And post-operative patient gained finger counting close to face with FAK correction. But this was done just before the lockdown, ma'am. And patient will be coming on follow-up. And it was finger counting close to face because previous to surgery it was perception of light, and he was able to perceive images at least.
What was the treatment like? What did you give post-operatively?
Ma'am, I cannot hear properly.
What was the post-operative treatment regime? What did you give?
Ma'am, post-operatively, like we gave antibiotics, and we gave topical steroids, and we gave cycloplegic, ma'am. Cycloplegic we gave, and we stopped over a couple of weeks, and antibiotics and steroids was continued now.
Since vitreous surgery is done, was there any role of giving systemic steroid also? Is there any role of systemic steroids?
Ma'am, in this patient, we gave systemic steroids. We gave for the first initial 10 days to 2 weeks, because there are few little bit of cortical matter which was like specks of matter, if has been missed, should not cause any inflammation. So we gave for a very short period. If the nucleus is completely removed, I don't think the systemic steroids might be needed, ma'am.
So vitrectomy, for the purpose of vitrectomy, what you've done to prevent vitreous fibrosis or anything, would you like to give systemic steroid for a longer time, or with a short steroid course you continue?
No, we gave
topical steroids.
Yes, ma'am. We gave steroids for 10 days to 2 weeks, ma'am.
Good, it was a good presentation.
Yes, ma'am.
Over to you, Dr. Raman.
A very nice surgery, Asif, very adventurous. I mean, could you judge the preoperative visual outcome? Obviously, the patient had this problem bilaterally for almost 10 years. Is there any way of evaluating his...
Sir, we did a visually evoked response in which the eye which we have operated showed, even though suboptimal response, there was some response, whereas the other eye, the response was almost extinguished. So in order to give some kind of ambulatory vision, we went ahead and did a surgery for the better eyes.
I was just thinking about, whether you look for any calcific spots or the thickness of the retinochoroid, because if it's below about 2 or 2.5, because in these cases, before doing such large surgeries, the visual outcome, of course, even counting fingers for this patient is a useful vision. I do acknowledge that. But did you look for this?
Yes, sir. In ultrasound, there was no chorioretinal thickening. There was no any signs of stages in which it is going into thicicle. There was no any changes of any calcification or degeneration. So we went ahead and did the surgery.
And I also noticed, it's a difficult surgery, but the globe was collapsing quite often. Yes, even though you had the side post, couldn't you have used a Fleringer ring? I mean, you get it in larger sizes also, that could have supported the...
Actually, we have done a series of cases. This was the first case we have operated. We realized that problem intraoperatively, and in the subsequent cases, we have used Fleringer ring. The ring came. First we thought like while putting this, there might be some problems with the inserting the ports, vitreoretinal ports. So we thought we didn't use it. But later we took a smaller size and the rings came in between the limbus and the ports. So it was
you even get them at the 18 millimeter size and all, which can go beyond the ports that you create, because that would make the surgery much more controlled.
Easier, yes, sir.
And I didn't quite like the way the nucleus fragment in the vitreous cavity was impaled. It just went freehand and there was no support to it. I mean, it could have easily gone ahead and damaged the retina. I mean, you think it could have been done a little better?
Sir, actually, we initially thought phacofragmentum to do, but the nucleus was quite hard, and even in ultrasound, we were able to see calcific spots in the nucleus. So it was quite hard, and especially in inflamed retina and very thin retinas, people have described impalation as a better technique of removal of the nucleus over phacofragmentum, because the small chips that's getting released during breakage of nucleus can even cause breaks in these retinas. So we went ahead and did.
And one last comment: in these kind of situations, even though these incisions, small incisions that you make are self-closing, it's recommended that you suture them up so that the globe maintains its integrity and the IOP is well maintained, which is important in this type of surgery.
Okay, sir.
Any comments on that?
Yes, sir. We used 23 gauge. So we could have suture, but there was no leak and hypotony, so we just massaged and left
on the table, but with a graft, and of course it becomes even more important with the decent graft. But then I would have, especially if it's not a 25 or a 27 gauge, I think it would have been a good idea to switch it up. Otherwise, well, I mean, it's always easy to make comments on hindsight, but I think a very challenging case, nicely handled.
Yes, sir. Thank you, sir.
Dr. Kumar, over to you.
Yeah.
I just had one question for Dr. Arif. Nice case. Was there any retinal injury subjacent to the point from which you impaled the nucleus? Because you need a little board support to impale such a hard nucleus. I thought I saw some hemorrhages in the retina when you went back to do the clearing up of the cortical matter. Was there any retinal injury?
I was also trying to make.
No bleed actually. Intraoperatively, we didn't find any bleed, or there wasn't any. Actually, the retina was already kind of with attenuated vessels and very thin retina. So there was no breaks or bleed intraoperatively.
I just want to share one tip here.
Yes,
one is, of course, the flaring and all that has been nicely told by Dr. Amurthy. The thing is, when you want to impale a nucleus such hard against the retina, which is offering resistance to you, and in the process you might be tearing up the retina or causing hemorrhages and edema. What you can do is just impale it till you are able to just lift it up. You don't have to really pierce it through and through.
Okay, sir.
Once it is up in the vitreous cavity, even up to say about 2 millimeters, go behind with the light pipe and then impale it further against the light pipe. So I think that is the way you can do it, provided you had done it instead of through the limbus, through the sclerotomy opening. I think you should have done a sclerotomy opening, gone through the sclerotomy opening with the needle. And one other thing that I would have done was to pre-place sutures to the temporary keratoprosthesis, so that you could release them, deliver the nucleus, and put them back for visualizing the retina through pars plana and inspecting the retina. So I think these are the things that I would have done differently.
Thank you, sir.
Thank you, Asif. And before we go to the next presenter, we request all the judges to please fill in the Google form for your score for all the presenters. So just a small reminder that you need to fill the form and judge all the presenters. So Sonu.
So next we have Dr. Parol Chawla Gupta, and I would request Dr. Amit Porwal to please introduce Dr. Gupta.
So till now everything is going on smoothly, and Sonu, if you see all the CVs of the presenters, all the presenters are great academicians. They are great researchers. Everybody has presented their work at various national and international forums, have got quite a number of publications. So it's my pleasure over here to introduce Dr. Parol Chawla Gupta. She's currently working as an assistant professor in PGI Chandigarh. She's trained under Dr. Jagatram and Dr. Fogla and has an experience of 10 years after ophthalmology. She's authored 96 PubMed Index publication, 16 non-PubMed index publications, and 6 book chapters. Her areas of interest include pediatric and adult cataract, lamellar keratoplasty, and community ophthalmology. So over to you, Dr. Parol. Request you to start sharing the screen. So as Sonu till she shares the screen, I was telling you, you see all our speakers, they are great academicians. You can see that the work they are presented by the publications and the presentations at various forums. So
I think this talent search has really brought up some very fascinating studies and great academicians all over the country.
Yeah.
So can you start sharing the screen, Dr. Parol?
Yes,
are you
sir.
there?
Yes, sir. My screen is visible to you?
No. You need to share the screen.
There is a share screen icon at the bottom.
It's a green color icon, Parol.
Parol, we can do that for you. You want Mr. Sunil to do that? Sunil ji, please go ahead.
So let her take a call. She wants to share the screen, or shall we tell Sunil to share the screen? Parol?
I'll try once more.
Sir, I'm sharing the screen. It's a video.
Okay. So Parol, Sunil is going to share the screen for you.
Okay.
Parol, we can't hear you.
I think she's not speaking. It's just music and the narrative.
You need to put the voice over. You want me to start it?
You have to restart. Then you have to speak loudly.
So then, Parol, what you can do is you speak. Sunil, you can just mute the volume in the video.
I'm muted, sir. I'm starting all over.
Yeah.
Yeah. All yours, Parol.
Okay, sir. So we are presenting the surgical management of a limbal dermoid. The case one was of a 20-year-old male who presented with a yellowish-white mask in both eyes with hair on the surface of the lesion. It was present since birth, gradually increasing in size and associated with foreign body sensation and irritation. He had a visual acuity of 6/24 in the left eye and 6/6 in the right eye. The anterior segment examination showed bilateral dermoid cysts. Ultrasound biomacroscopy showed clear angles. Limbal dermoids are chorostomas, which are normal tissue in abnormal locations, and there are various management options for them. Disadvantages of these techniques include persistent epithelial defects, conjunctivalization of the cornea, pseudopterygium formations. So we had this limbal dermoid with 8 into 5 mm size, and the lenticule was harvested on the artificial anterior chamber. Localized peritomy was done along with separation from the cornea. Hemostasis was achieved using wet field bipolar cautery. Then the marking of the circumference of the cornea was done with a marker pen, and corneal tattoo dye was applied on a dried surface. Along with 26 or 27 gauge needle bevel down to bury the pigment in the stroma. Then a glue-assisted graft placement was done, and contour repositioning was finally done. The histopathology was consistent with a dermoid cyst. This was the pre and the post-operative photograph of the patient. Then was the case 2 of a 6-year-old female who presented with a pinkish yellowish mask in the front of the right eye. She had a visual acuity of BCVA 612 The anterior segment examination showed a mass which measured around 6 into 5.5 mm. Lenticle harvesting was done in a similar fashion. A 6 mm skin biopsy punch was used to cut the donor tissue and the graft was separated. The localized conjunctival peritomy was done along with separation from the cornea. Hemostasis was achieved. Corneal tattoo dye was applied at the periphery and the graft was applied. Sutures were applied in view of the child being small and conjunctival repositioning was done. This was the final intraoperative image. Histopathological examination was consistent with that of a dermoid. A final pre and post-operative photograph. So advantages of this technique include good cosmesis and tectonic stability.
Thank you, Parol, for that wonderful presentation. I would request our lead judges, Aarti Lavangya ma'am and Dr. Honavar.
It is a very good presentation. And
thank you, ma'am.
Modality is really good because cosmetics is also really good. What
Yes.
to follow up? Usually these children, they need to be followed up for a very long time because in the long run, after many years, sometimes they change into malignancy also. And the refractive rehabilitation, the chances of amblyopia are quite high. And earlier the age of 30 years, the amblyopia control is better. So even before 6 years, even at the earliest when you operate, probably the vision
Yes.
and long-term success of the binocular is good. Otherwise, it was a very good surgery. Cosmesis is also very good. And histopathological examination of all these specimens is also important because sometimes it could be a little bit different etiology. Though it appears like a derma, it could be something else. So not to presume all these limbal tumors with hair or whatever it is directly without doing the histopathology, not to presume as learning. And very long-term follow-up for several years, 10 years, 20 years is necessary in all these patients.
Yes, ma'am. Thank you, ma'am.
Dr. Santosh?
Yeah, a couple of questions. Very nice video, Parol. I have a couple of questions. I thought that you did a very superficial excision, isn't it? Flush excision almost. You didn't go deeper into the cornea. So what is the need for a superficial lamellar keratoplasty? That is one. Second is that obviously these patients had amblyopia not because of anything else but astigmatism. There was no visual deprivation as such. The lesions were away from the pupillary axis. So would you at least in a 6-year-old child, would you combine this procedure with some astigmatic alleviation procedure, refractive procedure for management of astigmatism, then do amblyopia treatment? Or with such high astigmatism, would these children be able to tolerate spectacle correction? Or would you consider contact lens at all? Or were these purely done for cosmesis without any kind of thought process for visual recovery?
So they were mainly done for cosmetic reasons. Both the patients came to us with the main complaint of visual, it was a cosmetic blemish for both of them. They realized that the vision was less only on our examination. So it was mainly done as a visual cosmetic problem to address the cosmetic problem. And the child was followed up on spectacles with part-time occlusion therapy. In fact, the occlusion therapy was given in the adult also. But and the first question of yours, sir, was that I did a very superficial dissection. That was because I just didn't want to have the ectasia of the limbal girdle. I wanted to preserve the limbal girdle as well as is shown in the study by Dr. Susan Jacob as well as Dr. Amar Agarwal, they have showed that a very superficial dissection, it preserves the limbal girdle and prevents operative ectasia, which is usually seen in these patients operated for limbal dermoids. So I did a very superficial dissection, applied the dye so that the whitish background base was hidden by the dye, and then applied the graft.
Well, why did you consider this as an option, considering that you could have done a near total excision deep lamellar keratectomy with DALC? Was that a consideration at all?
Yes, so that could have been a consideration, but I wanted to do a superficial dissection because even the DALC, we have seen in some patients, even with the peripheral DALCs, it leads to ectasia because of the loss of the limbal girdle effect. So that is why we went ahead with the superficial dissection, which did not disturb the limbus.
I think ectasia is not such a big issue, especially when you're doing dermoid excision, Parol, and that too the peripheral part, which is quite thick. And I felt that you could have, even if you had left it like that, there's, as the child grows, the eye grows, there's very little haze which remains in the periphery. And I think I agree with Santosh that addressing their astigmatism is important, whether you do it with a contact lens or whether you do it with a spectacle, or because that is one thing that should be taken care of, especially when you're doing in children. I don't know, ma'am. I feel that ectasia is not such a big issue, and it doesn't become ectatic from there. And that's not you're not doing graft for that basically. You're basically doing intrastromal tattooing and then putting a graft there. Most of them we just shave off. We don't bother to put the graft unless they're really deep.
Deep.
With the graft interface vascular evolution is also a problem. Deep interface vascular within the graft interface. So keep it bare and apply porphyrin on that for the chances of recurrence are less rather than putting it.
Yes,
So thank you, Parol. So all to you, Amit, for the next presentation.
Yeah. So our next presenter is Dr. Ritesh Verma. And to introduce him, we have our Dynamic Scientific Committee member, Dr. Somshila Murthy. The lead judges for Ritesh's presentation will be Dr. Prashant Bavankule, and request Dr. Guru Prasad also to be one of the lead judges. So over to you, Dr. Somshila.
Thank you, Amit and Sonu. As both of you mentioned, that it's really exciting to see how much talent there really is and how prolific all our presenters are at the young age. This is really one of the very exciting programs that we are proud of as members of the scientific committee and with Dr. Partha Biswas that we've been running nationwide. And also all of you have noticed that how much we're learning from all the judges. So for all the presentations. So Ritesh is coming up next, and he's from Ludhiana. He's from RIO. He is also multi-talented, and he has published at least 10 international publications as well as some regional publications. He has presented 5 national papers and also several posters at various fora. And he's won the first prize in AIOS quiz in 2019. So all the best, Ritesh, and I'm sure you'll do a good job with your talk on ROP.
Thank you so much, ma'am. Am I audible?
Yeah, Ritesh, you are audible. So
yes,
start sharing your screen.
Yes. Is my screen visible, sir?
Yeah.
Is my screen visible?
Yeah,
sir?
it is visible.
So good evening, everyone. I'll be talking about the reactivation of ROP following bevacizumab monotherapy in AP-ROP. So why I have written it as a wonder drug in my first slide is because it causes immediate regression of AP-ROP. So this is as evident by this picture, which was taken 2 weeks after the injection. So reviewing the major landmarks in the context, the AP-ROP was defined in 2005 by ICROP, and in 2011, the BETROP trial propagated the use of bevacizumab in ROP patients, which was followed by a literature boom. And again, the BETROP group again published in 2016, tackling the reactivation after the injection. And in 2016, when there are so many gray areas on the use of bevacizumab, we now have the RAINBOW trial, which is propagating the use of ranibizumab. So we started investigating the drug, and we started to find out the incidence of AP-ROP at our institute and the timing and risk factors for reactivation of ROP post-injection. We also tried to define the follow-up period post-injection and the use of green laser in the treatment of reactivation and the intraocular pressure variation after the injection. So we conducted this study from August 2019 to July 2020. wherein we injected 0.6 to 5 milligram bevacizumab in a single sitting in our under aseptic conditions. So we injected the drug 1.5 millimeter from the limbus by directly visualizing the 30 gauge needle behind the lens to avoid any damage to the lens, and injecting the drug in the anterior vitreous cavity, and then providing a tamponade for 2 to 3 minutes. The post-operative regression was defined as complete disappearance of tunica vasculosa lentis and complete disappearance of plus disease and neovascularization. As you can see in this picture, which was taken 4 weeks post intravitreal, which 4 weeks post injection. And reactivation was defined as recurrence of plus disease or progression of retinal neovascularization either at the original edge or at the anterior edge secondary to retinal vascular proliferation. So in this image, you can see there is a ridge formed in the zone 1 at the original edge, and this image was taken 12 weeks post injection. So talking on to the incidence, a total of 355 patients were screened during our study period, and the incidence overall of ROP is 27.6%. The incidence of AP-ROP is 3.38% at our institute, and we injected bevacizumab in all the 24 eyes that had bilateral AP-ROP. So on univariate regression analysis, we found out that multiple pregnancy, the lower mean birth weight, neonatal sepsis, and necrotizing enterocolitis were associated with the reactivation. The reactivation rate at our institute was 33.3%, that is 8 of 24 eyes had reactivation. So other studies have quoted that SWARE ROP, the reactivation rate is 31 to 41%, and various treatment modalities have been advocated for the reactivation, but we performed laser in all our reactivation cases. So the mean time between initial treatment and reoccurrence was 11.8% as compared to the West, which I reported 19.2 weeks. And all the patients had zone 2 reactivation except one patient which had zone 1 reactivation that I showed earlier. All patients had good outcome after green laser therapy. So we measured intraocular pressure with a tonopen on preoperative day 1 week and 1 month post-operative. And we found out that there is a significant rise in IOP from baseline of 15.7 to 22.5 on day 1, which returned to baseline at 1 week and 1 month follow-up. So coming on to follow-up, it is very difficult because it is not well defined in the literature because of the varied regression patterns of AP-ROP. We follow up all our cases weekly for the first 3 months, then bi-weekly for 3 months, and then monthly till complete vascularization of the retina or till we have performed the laser because we do not have FFA. So coming on to green laser, the safety of green laser has already been established in ROP. The technique is pretty much same as that compared to the conventional ROP, and the timing of is very important because we perform delayed laser when there is reactivation, because adjuvant laser can cause early reactivation by early washout of the drug from the vitreous cavity. There was no significance of HB levels in the reactivation group, but I will like to show this case where we had reactivation, delayed reactivation at 30 weeks because the HP level falls to 4.8 in that child. So systemic parameters should be monitored in these cases.
Ritesh, your time is up.
Yeah, sir. So the key messages are there is a risk of reactivation because of persistent of avascular retina, and delayed laser should be performed, and transient IOP rise should be expected after the injection. Thank you. That's all.
Thank you, Ritesh. So the lead judges for your presentation is Dr. Bhawankule and Dr. Guru Prasad. So I request Dr. Bhawankule, Prashant to start the discussion.
So Ritesh, how much was the volume of the drug which you injected?
So 0.025 ml, half of the adult dose.
Half of the adult dose.
Yes, sir.
And in spite of that, you have recorded the pressure immediately post-op or
no, sir,
first day?
We recorded the pressure on first day. We did not record because of the speculum. The IOP rise is expected, so we try to measure it on first day.
No, I mean it means if you had on a first day 24 or 24 millimeter of mercury, it means immediately post-op because of a small globe and the volume which we are using is 50%.
Yes.
The pressure rise would be more high and it would be more harmful. So shouldn't we have studied that better?
So we have studied that after applying the speculum, the IOP is bound to rise up to 33. So we are doing another study in which after, even if we are examining a child with an Alfonso speculum, the IOP rise is bound to occur.
Yes, but you can do without the speculum, you can do the rise. If
yes.
It is so significant in your study, yes. The pressure spike which you are talking about 24
yes.
hours later is. Second thing, what I found was you have multiple questions which you have tried to study in a single set of studies. So actually, such questions were multiple to be answered in such a short period and in such a small study.
Sir, actually,
how many questions did you try to analyze?
Sir, actually, this is not a single study. I tried to combine multiple studies to, complete it in 4 minutes. But we have done 2 separate studies. which we have reviewed the intraocular pressure retrospectively, not prospectively. But all the incidence and the risk factors were assessed prospectively.
Other thing is, you said reactivation or so-called recurrence was seen in only patients who had some systemic deterioration over a period of time. Is it true? That is what you tried to say, or what do you mean?
No, sir. So these factors were significantly associated with reactivation. They were not present in all the cases of reactivation, but the p-value was significant, that there is a significant difference in the two groups. But our sample size is not that much that we could validate our study. So we are currently working on that, sir.
So out of the 24, how many had the recurrence?
8 eyes had reactivation, sir.
8 eyes had recurrence. And so how many of them had this associated systemic deterioration which you can attribute? And how many had the recurrence without having any systemic deterioration?
So most of the patients had necrotizing enterocolitis, but sepsis was present in 3 of them. Those had reactivation. I mean, 3 of the infants. So infants and eyes are, I think, difficult to manage. So there are only 4 infants. We can, talk about comorbidities. So it is very less as compared to the number of eyes. So we are comparing 12 eyes with 12 infants with 4 infants. That is not correct, sir. So the sample size needs to be more to validate these. But these are the initial results that I am showing, sir.
Okay. Over to Dr. Guru, sir. Yeah. What was the mean chronological age of these babies? Yeah. Can you hear me?
Yeah, can hear you.
Yeah. So what was the mean chronological age of these babies when you took them for laser treatment?
Sir, we took them. Sir, as of now, or around 10 of the babies we have lasered. I mean, so out of 24, 20 eyes have been lasered. But we tried to laser.
The chronological age when you lasered, I wanted to know.
When we laser on first, when we first saw reactivation, we lasered them. So at 45 weeks, 45 to 55.
So did you need general anesthesia in any of these babies?
No, sir. We perform laser in our OPD only, sir, under topical anesthesia.
Okay. So was it difficult or was it okay? Were you comfortable doing the laser for these bigger babies at 45 weeks?
Sir, it is not difficult to laser these babies under topical anesthesia, sir, but we have found that the one child that had reactivation at 30 weeks, it was quite difficult to laser that area. But I think at 45 to 55, sir, it is not very difficult to laser.
What was the mean zone in terms of distance from the periphery posteriorly of these reactivation cases?
Sir, only one. Sir, only one infant had zone 1 reactivation in both the eyes. Rest all of them had zone 2 reactivation. So the mean number of spots, sir, we have also calculated. So it was around 1500 in zone 2 reactivation and 4000 in zone 1 reactivation with green laser.
Did you see any difference in the response to the laser treatment in these bigger babies as compared to the response that you normally see in these when you treat laser as a primary modality of treatment?
So what we saw was the reactivation in zone 1 was more of a ridge kind of, and in zone 2 it was more of.
No, I'm talking about the response to laser.
Yes, sir, I'm coming to that. Okay. So what we saw in zone 3 in conventional ROP cases is that ridge is attached to the retina, but in these cases we do laser, even we don't see, even if we see an early ridge. So pretty much they behave the same, sir. There's no difference.
And one thing to Prashant and to Dr. Ritesh is whether you agree with the distance from the limbus that the injection was given. I think it is a little far. I would rather be just about half a millimeter away from the limbus and go vertically backwards rather than towards the mid-vitreous cavity to inject in these small babies. Otherwise, I think you are probably, the pars plana not being well developed, you are probably injuring the pars plana and the ora serrata.
Yes, sir, we do it from the pars placata route, sir. The pars plana is not developing.
No, that's what, you don't know where it is, and therefore I think closer to the limbus, the better.
Yes.
Your video showed it quite behind.
Quite behind. So you said 1.5 millimeters, which is, I think, pretty much too much.
Too much.
Yeah.
But there is a risk to injury to the lens, sir, because the lens.
No, you can. No, that's why the direction has to be vertical rather than towards the mid-vitreous cavity, so that you don't even go close to the equator of the lens.
Yes, I agree, sir. I agree totally.
Over to you, Amit.
Thank you, Ritesh, and thank you to Prashant and Dr. Guru. So now we continue with our next presentation, and to introduce the next speaker, Dr. Saurabh Kamal. He is our next speaker, and I'm going to introduce him. Dr. Saurabh Kamal is currently working as a consultant at IHub, Faridabad. He did his senior residency from Guru Nanak AIOS Eye Center, his fellowship from LV Prasad, Hyderabad, He authored more than 80 publications and won 9 awards. He has over 50 national and international faculty presentations, and his areas of special interest include technology. So over to you, Saurabh, and the lead judge for your presentations are Dr. Santosh and Dr. Kumar.
Can you see my slide?
Yeah, Saurabh, your slides are visible.
Can you hear me also?
Yeah, can hear you.
Thank you, Dr. Parol. So I'm
your
starting.
Your face is not visible. Yeah.
Is it visible now?
No, it's okay. You can go ahead with your presentation.
Yeah, thank you. So good evening, everyone. My topic is intranasal cyst in congenital nasolacrimal duct obstruction. With the increasing use of nasal endoscopy and case-based approach in CNLDO has caused the paradigm shift in the management of CNLDO. This has led to the recognition of intranasal cysts, which are primarily seen in congenital seals. Now, this cyst occurs because of the increased LD. These large cysts can cause respiratory insufficiency, recurrence after probing, and acute dacryocystitis. Their management has been well documented in form of cruciate marsupialization. But author has believe that there are intranasal cysts which can occur without the dacryo seal. And these occur because of the abnormal development at the lower NLD as depicted by Jones and Bobbe. Therefore, the purpose of present study is to describe the clinical feature types and outcome of intranasal cyst. This was a retrospective case series by a single surgeon. All children underwent nasal endoscopic guided probing. Anatomically, the cysts were classified as small, if large, if they could be seen without the need of medialization of turbinate. All cysts underwent cruciate marsupialization. Only cases with minimal follow-up of 3 months were included. Over 4 years period, 34 eyes of 33 patients were included. The incidence of intranasal cyst was 12.5%. Mean age was 18.7 months. There was acute dacryocystitis at presentation in 6%. There was history of probing once in 41% and twice in 15% of the cases. Dacryoceal was noted in 6 cases. On anatomical classification, small cysts accounted for 74%, and on clinico-pathological classification, there was equal proportion of simple and complex. Complex were further divided into fibrotic, abscess, multicystic, and thick wall. 41% of the case showed sac atonicity. On further subgroup analysis, all children without dacryoceal had small intranasal cyst. All children with dacryoceal had large intranasal cyst. Within the simple intranasal cyst type, small accounted for 61% of the cases, and in the complex type, small accounted for 87% of the cases. Mean time to resolution was increased because of the sac atonicity, and success rate with probing was noted in 94% of the cases. On nasal endoscopy, this small, simple cyst can be noted on medialization of inferior turbinate, which is undergoing cruciate marsupialization with 2 perpendicular incisions, and further 45-degree probe till test to ensure the complete opening followed by fluorescein irrigation. This child having acute dacryocystitis was noted to have small white to yellowish intranasal cyst and therefore underwent drainage and administration of systemic intravenous antibiotics. In this case, after cruciate marsupialization, thick mucus was seen over probe, and on 45-degree probe test with back and forth movement, further drainage of the pus can be seen, suggesting multiple loculations. This was a case of a flat, small fibrotic cyst, which can be difficult to appreciate and missed endoscopically, is undergoing cruciate marsupialization and probe tail test with fluorescein irrigation. To conclude, intranasal cysts can be seen in CNLDO with or without dacryoceal. This is the first study to propose the classification of these cysts with clinico-pathologic correlation. We believe that this classification, along with key factors in management as discussed, will lead to better understanding of this rare and intriguing disorder with eventual high successful outcome. Thank you.
Thank you, Dr. Saurabh. So over to you, Dr. Santosh.
Good presentation, Saurabh. Very nice documentation. As we resort to endoscopy as part of probing for CNLDO, we are encountering all these issues which earlier were unrecognized. In fact, in congenital dacrocystocele, it was always believed that cysts exist. But in congenital nasolacrimal duct obstruction, cysts were not even documented earlier. Now, there are studies which show about 3 to 5% incidence. Your incidence, I notice, is very high, 12+%, 30 odd cases in 4 years, which is possibly the highest ever. So I wonder why. That is one. Second is you have mentioned that you have done clinico-pathological classification. When you did marsupialization cruciate, especially, the kind of sample that you would get is very minimal. Or did you excise the wall completely or nearly completely and send for histopathology? And what are the actual implications? Because whether there is a cyst or not, large, small, fibrotic, whatever, the final management is just marsupialization of the cyst along with probing, isn't it? So how would it affect your success in any way, classification or subclassification using complex terminologies, or all are managed similarly?
Yeah. Thank you, Dr. Santosh, for. So with first question, like the greater incidence was noted in my study of this cyst, would be because mainly I'm getting most of the cases as a referral cases, mainly in the form of the secondary surgery requiring or those complex cases. So that could have resulted in maybe higher incidence. Secondly, these intranasal cysts are important to divide, which I've like documented, maybe because the all approach doesn't fit one. Like we have various CNLDO types apart from these intranasal cysts, but even within the intranasal cysts, if you see, some of them can be easily missed. So that was my initial way to look into this retrospectively about intranasal cysts, because these small intranasal cysts, especially the fibrotic one, they are difficult to appreciate. So once you pass the probe and you don't see the probe on endoscopic and you see any elevation, then you diagnose that the patient is having intranasal cyst. Then further, as I have shown in the like 4 videos, especially like for loculations, cystic having a loculation. So what is most important is the 45-degree probe tilt test, because you have to pass the probe back and forth multiple times, so that you break all those loculations and ensure that the mucus, whatever the mucous membrane and cyst is there, has opened completely. It's again same for the thick wall, because thick wall may be difficult to deal. When you incise with the sickle knife, they may have partial thickness. So if you are aware of this type, that they can have thick wall, you will go with a one sharper instrument. So in those cases, you may even need crescent knife. So crescent knife is a very sharp 2.2 mm rather than the sickle knife for using it, because this is a fresh equipment, reusable, disposable instrument, so that you may need. Again, if we classify these into abscess type, if you like, I had only 2 cases which are having acute dacryocystitis at presentation. But in the abscess variety, they were like 4 cases of the abscess variety. So clinically, they were not having acute dacryocystitis, but on intranasal examination and probing, they were having abscess kind of an intranasal cyst. So if you recognize them, yes, it is an acute infection. Obviously, we have to give systemic intravenous antibiotics also. So I believe that, yeah, this, although they have cruciate marsupialization, the basic steps are same, but in order to achieve the move towards a more higher successful outcome, you have to identify and manage accordingly.
Identification is, in a way retrospective, because it's on the go identification and on the go decision making. You have to be prepared for any eventuality when you encounter a case like this, because when you first see the cyst, just at the face of it, you'll never know whether it is multiloculated at all or not. And in any case, a 45-degree probe test is warranted in any patient, isn't it? I mean,
yes, I agree.
Yeah.
But all those like findings, they were documented and they were then put together to make this classification go.
What about histopathology? I didn't see any picture. Was there any histopathology done, say clinico-pathological, or just pathological is a term that you used?
No, pathological is like correlating with like of the cyst pathology, correlating with the clinical manifestation of the patient. Pathology, like the earlier studies, they have marsupialized the cyst. They have entirely removed the cyst. So which is believed to cause, healing by secondary intention. With cruciate marsupialization, when you incise, you make four flaps, which can, tend to divert away. So that leads to the healing in a primary intention. So that was the purpose. But if it is a very large cyst, the dactyliocele, then some part associated with external dactyliocele, if it is a very large cyst, then obviously some part of the cyst can be removed in them, not with the small.
So probably you cannot use a term pathological classification because pathology would mean pathology.
My purpose was pathology based on on endoscopic finding. Yeah, so agree. Okay.
Clinico-morphological maybe.
Clinico-morphological, yeah, would be a better term.
Over to you, Dr. Kumar.
No, sorry, I don't think I have the competence to talk, but I would like to lighten the mood. And you see, I'm reminded of Abraham Lincoln's quote. It says, "It's better to keep your mouth shut and let others believe that you are a fool rather than open it and clear all doubt."
So any other judges have any other questions for Dr. Saurabh? So no, I think we are all running the whole show on exactly on time. Partha, we are not delaying. Our speakers are getting stuck to the time, and our judges also are sticking to the time what has been allotted to ask the questions. And all our speakers are being nicely grilled by the judges. That's the best part I'm seeing in the talent show, that nothing is superficial. They are nicely grilled. What do you think, Sonu? With all the talent shows we have conducted till now, every talent show.
That holds true for all, yes, very true.
Yeah, and also would like to mention that the whole show, these 5 talent shows, what we are conducting in all the 5 zones, Partha, we all know how much INTAS is supporting us for this program. I mean, we can't forget INTAS because it is because of INTAS that the great talent has come out from the whole country.
Absolutely. Absolutely said it well.
So now I invite Dr. Sonu to introduce our last speaker of the North Zone Talent Search. Sonu, over to you.
So Dr. Veer Singh is a young, dynamic vitreoretinal surgeon working at the SP Dr. Sohan Singh Eye Hospital, Amritsar, Punjab. He completed his surgical vitreoretina fellowship at the Shankara Nethralaya, Chennai. He has cleared his FICO Retina UK. He has authored many publications and has multiple presentations. And his major area of interest is vitreoretina and uvea. The lead judges for this presentation would be Dr. Ayachit. And I think we can request Dr. Prashant to be with us. And
Dr. Prashant and Dr. Kumar also.
And Dr. Kumar as well. Yeah. So all to you, Veer, and you can start sharing your screen now.
So Sonu, just to mention, Veer is a Belgaum alumni. He's an alumni from Jain Medical College, my parent institute. So I always feel proud to mention my college name whenever any alumni member is presenting in this.
Yeah. So, but I know that you are not judging.
I'm not judging. That's why it's okay. And nobody is there from Belgaum, so don't worry.
Thank you, sir. I'd like to thank AIOS and POS for giving me this opportunity. I'm going to be showing my mini PVD technique, and it's used in managing challenging PDR cases. So there's no financial interest, but I have a disclaimer that this video won the runner-up award at IRSI Awards this year. In diabetic TRD vitrectomy, the difficulty level all depends on whether there's a PVD or not. In case there is a PVD, the membranes are lifted up like in these 2 pictures, and that there's a clear dissection plane. There's plenty of space to work with. So case is easy. In case there isn't, so there's no place to work, the membranes are flat, and it's a very difficult case. So in these flat membrane TRDs, one always tries to locate a membrane edge, lift it up, try to get into the correct plane, and then work from there. But the problem is a lot of these cases are vitroschisis, and you end up in the false plane. This is where my mini PVD technique comes in handy. I never search for a membrane edge. I go straight to the disc and lift up the hyalod from there just by 1 millimeter or 2. This gives me a small PVD around the disc in that green zone and creating space between the retina and the membrane. Opening that gets me right in the correct plane of the second membrane, making surgery very fast, very easy, and alleviates the need of switching on to bimanual surgery ever. There's never a need to search for a membrane edge. 10K bevel cutter, when you combine it with this, it's got a unique shape, helps you work safer, closer, and along the retinal contour. So there are 2 cases that I'd like to show videos of demonstrating this technique. In the first case, this is an advanced PDR case. I don't look anywhere, just go straight with my forceps to the disc and just lift up the hyaloid a little bit. And you see that arrow, PVD is extended just till there. And on the nasal side, just a PVD, just to get an opening to create an edge rather than finding an edge. And then I engage my cutter there, and then I start from there. If you notice, the membranes come so easily because I'm in the correct plane. I don't have to make any effort, and it's pretty much like a cakewalk. Everything just jumps to my cutter. And in fact, even this adherent membrane, there's no bleeding because I'm in the correct membrane. And all I'm doing is just extending that edge of that mini PVD that I created. On the nasal side, they're usually very strongly adherent. So you have to do it again. And just freshen up that mini PVD, get that edge created artificially. And you see how the retina just folds back into the cutter. And it's just cakewalk from there. And that same edge you extend into the periphery, get those membranes up there into the cutter, and not much to be done further on. And then that's the last part of the membrane, which just comes by a fold back delamination. In fact, this patient did very well and got 6/12 vision at 8 weeks. In case 2 is a similar case. Again, this is a flat membrane. I'm just clearing up the hemorrhage. In this, I use a cutter. At a very low suction, I just try to induce a PVD. And you see that blood that starts gushing. That tells me that the PVD has been created and there's been an opening. And I move on from there, extend the PVD just by 1 or 2 disc diameter, just 1.5 disc diameter. Again, doing the same thing nasally, not causing traction on those adherents, the strongly adherent points. And you see how beautifully this beveled cutter, the shape, it goes right into those spaces and helps me work so close to the retina without damaging the retina. Again, on the nasal side, because of the adherence, I freshen up that mini PVD. And when I have that edge, it's just, again, so easy to extend that into the periphery. And then superiorly, again, that same edge that I created initially, I'm working on that, mechanically dissecting. And you see that bevel cutter, that shape is so amazing that you can just sit on the retina and cut those membranes. I'm literally touching the retina, but nothing's happening to the retina, and all the membranes are coming. In fact, that's the last part of the membrane. And you see there's a bleed here. Now you see a bleed. You can use the same tip to give mechanical pressure and control the bleeding. The shape is such that it aligns so well to the contour of the retina. Again, extending that same edge further, no need to find a new edge. And that's the last part of the membrane, which comes off very easily, lifting that last part of hyaloid and finishing up with the ILM peeling and endolaser. And that's how the case looks in the end. So these are some of the cases managed by this technique. So I'd just like to conclude by saying that, using this technique really eliminates the need for a bimanual surgery, and you have very fast and very efficient surgery with this technique. Thank you.
Thank you, Veer, for that wonderful presentation. I think more than the cutter, it is the man behind the machine. And congratulations.
Thank you, sir.
So can we have the lead judges?
Nice presentation, Veer. That was a good display of your deftness. But I must say that no 2 cases are similar when it comes to diabetic vitrectomy. So you can't say that this will work for all cases. This particular technique will work for all cases. Maybe for flat membranes on the disc and spreading beyond the disc are the cases which will benefit by this technique. In fact, I belong to the generation where we graduated from the 20 gauge era. And during the 20 gauge era, we didn't have these micro instruments, and we used to work from the disc peripherally. It was always inside out. We used to call it inside out technique, where we used to tackle the disc membranes first and then go towards the periphery, because we believed that the posterior retina is thickest. And as you go to the periphery, the retina becomes thin, and that is where you should probably stop. So, and one more thing is the problem comes in diabetic vitrectomy usually at the arcades. You can get away with the membranes easily. You can do the membrane surgery at the disc in the periphery as well. But at along the arcades where the adhesions are very strong, that is where the problem comes, and that is where you have to look for the correct plane. And if you fail, you probably have to resort to bimanual surgery. I think you got away very well with this without any complications. But I think the bottom line of what I'm trying to say is that no one technique fits all. No one technique suits all diabetic vitrectomies. Prashant and Kumar.
Yeah, exactly. That's what I would echo my sentiments here. Same. Yeah. The thing is, inside out or outside in. Inside out, we used to do previously because we had smaller viewing angles, field of view. And so we prefer to move from this towards the periphery with the concept that the central part of the retina is more thicker. But now with the wide angle viewing system, where you can have a panoramic view of the whole retinal architecture, and in fact, retinal and interrelation between membranes and retina are better seen in this. So many times you will realize that when you're seeing with a 90-degree view, you can actually, you go from periphery, induce PVD in the periphery and come centrally, it becomes more easier. What I observed in your cases where all of them were naive PDRs, predominantly fibrotic type of a membranes, and these cases otherwise also do well, be whatever technique you use, and yes, 70% of them can be managed by this. But if you have an associated what I should say, atrophic type of tractional detachments associated with it, bimanual still has a role. Otherwise, you will end up, in spite of using a 10K cutter, creating a nitrogenic breaks. That's what I feel.
So, sir, can I make a comment?
Yeah, please.
So, sir, like sir asked, this technique, especially I used to, when I started off, I used to face a lot of difficulty in these flat membranes. So this specifically, is, I found it very useful just in that space, those flat membranes. And yes, of course, bimanual, you can never replace it. But, when I creating that space really has, earlier I used to do a lot of bimanual surgery. On the contrary, ever since I started doing this, it has really gone down. I'm just able to manage with, unimanually with this.
I think you rightly said, instead of finding the plane, you have to create the plane. That holds very well for this particular type of scenario. Finding the plane for flat membranes, by picking it up and then sort of inducing a PVD, as it were, not for the cortical vitreous, but for the membranes. But you have to be very careful, watching the retina all the time, looking for traction on the vessels, which will cause bleeding, sometimes uncontrollable, and sometimes breaks, which are quite posterior and big, and that is what ends up, a lot of problems. So you should.
My fear most of the time, but most of these cases I end up using pre-operative anti-VEGF, so that has really worked.
Correct.
So before we take the question to Dr. Kumar, I would like to request all the judges to please fill in the Google form, and after Dr. Kumar finishes, please give the marks to Dr. Veer and press the submit button, and it will take 5-10 minutes for us to collate the results before Dr. Partha announces the results. So over to you, Dr. Kumar.
Nothing much. Enough has already been discussed by Dr. Guru and Prashant. We need to have multiple arrows in our quiver, as it were, so to say, when dealing with different types, and each PDR differs in finer details, that no two cases are similar, and we will have to use whichever is suitable for the case. So horses for courses kind of a policy. So this is one other.
Dr. Kumar, you muted yourself.
Yeah, I already was I audible in the previous?
Last sentence was not audible. The last sentence was not audible.
Yeah, I think we should have a horses for courses policy and use the technique that is apt for a given case. And this is probably one other method of dealing with PTR. I wouldn't say that it will replace bimanual, but this is one other method that we can have in our armory.
Thank you, Dr. Kumar, Dr. Guru, and Dr. Prashant. So we come to the end of this show. Now, before we announce the results, I request once again all the judges to please submit the Google mark sheet. And it has been wonderful throughout. We have finished on time. So now I request our Chairman Scientific Committee, Dr. Partha Biswas, to take over and invite comments from our judges and our young talent Turks, what I call young Turks. So over to you, Partha.
Thank you very much, Amit. That wonderful, conduction and in time, which we usually do not stick. But this time we have been on time, and thanks a lot to both Sonu and to yourself for that. Our judges, Dr. Bharti Lavingya, ma'am, any comments from you about the quality of the presentations? Of course, as soon as you have uploaded your mark sheet.
It's wonderful. The whole program is wonderful, and you find many talents. So this is the way when you make people go ahead. India is going ahead in ophthalmology. because of all these attempts. It will go a long way in academics. Wonderful, very nice.
Thank you very much, ma'am. So have you given 10 out of 10 to everyone?
Not all, because there are certain changes here and there. There are presentations. That is, attempts were very good.
Thank you, sir. Thank you, ma'am.
Inclination towards academics is wonderful.
Dr. Guru Prasad, sir.
So Guru Prasad sir, this is not about dance or songs. This was pure academics, pure science.
No, that is why I was shying away from this being a judge in the beginning. And I, in fact, apologize to Dr. Partha for fussing about not accepting immediately. But when I came to know it was about vitreoretina, I immediately jumped at it and accepted it. Thank you, Partha, for persisting with me. And thoroughly enjoyed. It was a really a learning experience for me also. All the contestants, all the participants were really very good. And I don't think there'll be any clear winner in this. It's very difficult to judge, I think. That I leave the final decision to Partha, of course. And thank you once again for...
The final decision is not to Partha. The final decision is the collation of all the marks given by the judges.
No, he has to use,
so the speaker should not think that we are biased to anybody. It is the collation of all the marks.
Properly.
I'd like to tell this also that not that Belgaum guy is going to win just because Amit is from Belgaum.
Santosh, from you?
Judges who are judging. We are not a part of the judging thing. It is good for us.
Santosh, over to you, Santosh.
Very nice concept, Partha. Enjoyed it. Really very nice. Very good presentation.
Thank you. Ramurthy, sir.
I think Indian ophthalmology faces a problem of plenty now. I mean, there's so much talent.
We should export some of them, I think.
No, I think a wonderful concept and very well done. And I think there's so much of super specialization that much of what we hear from others sounds like Greek and Latin, but it's excellent to listen to all this. And truly proud of all the youngsters and wish them all the very best in whatever they do going ahead. I think I'm very glad that Indian ophthalmology is in safe hands and we have a very bright future ahead. As Namrata noted, there are 3 papers on posterior polar cataract, anterior segment OCT. I think all 3 have been from Indian authors. And I think that truly indicates the shape of things to come. We'll dominate over the world of ophthalmology in the days to come. All the very best.
Dr. Kumar.
Yeah, excellent presentations by all the presenters and kudos to Partha. One very important point which was missed, and that was made by Dr. Santosh, is that as ophthalmologists, we should not be concentrating only on the anatomic outcomes, and our basic goal is to restore vision in patients. And in the presentation on limbal dermoids, a very important point about functional recovery in the form of addressing amblyopia in that case was very well brought out by Santosh. So we should always not lose sight of the fact that as physicians, as ophthalmologists, as ocular scientists, our basic goal should be visual restoration and not just anatomic restoration. The first presentation by Dr. Abhinav, I would like to know whether that was done on prezi.com or what was the mode of presentation to something different. I just wanted to know.
Sir, I just made a video.
Okay.
So the software used.
I just made an animation of myself only.
Just a comment on that, Abhinav. You were compromising on the size of the font because you were sharing half the screen. So we were not able to see the fonts very well, especially on my small laptop. It was very difficult. So I think, no. I think
good eye surgeon to treat your eyes.
Okay. Are you hinting that I should come to you?
There were a couple of presentations where the font size was small, where the aspect ratio of the video was also less. So, they were kind of coming in the right in the center, and the other part of it was not, other part of it was kind of dark. So I think those are the things which you should pay attention to, because it is the judges, their laptop, which they are watching. So those things should be looked at when you are, presenting.
So, Prashant, over to you. Any comments from you? Prashant? Prashant is not there. So comments, Prashant, Partha, we invite comments from our speakers, or the result is out.
Why not? Yes, please.
It was a great show. Thank you, Amit, for those things. Few of the presentations were really where we learned some things. In first two things were about anti-segment. I learned a lot. It was I was wrongly placed as a judge there because that's not my cup of.
Everybody knows you do more cataract than retina, Prashant.
No, dear. This type of complicated nahi karta hai. Refractive surgeon, I am not a refractive surgeon. But great. Seriously, it was a learning experience for us as well.
So, Abhinav, what is your comment about this program?
So it was an
webinar I learned here.
Good. So, Abhinav, from your side?
It was an amazing show, sir. I think I also learned a lot of few things which I also didn't know. So it was a learning experience more for us than a presentation, actually.
Veer?
I would just say that, this is it's a great, webinars are happening all the time, but it's a great initiative to bring out, the hidden talents in all the different zones, and it's a pan-India program. So I think that's very great about that.
Yeah, Aniruddha?
I think I really personally enjoyed it a lot. I like this format where so many specialities are brought together and so many ideas are brought together. I think it's a great learning experience, especially when it's outside your specialty and you're getting to learn. So I think I like that.
You're forced to sit here because you have to present. So you're forced to look at others' presentations also. Otherwise, if you're not in a virtual platform, you would probably never go. To see, what is happening.
Absolutely.
Yeah. Saurabh, your comments on this program?
Yeah, that's a great initiative. I think AIOS Scientific Committee on PAN. I agree with Dr. Aniruddha that you get a good opportunity to get exposed to these different specialties, especially like I'm being very restricted to oculoplasty. So seeing a lot of these retina cornea things and glaucoma, that's make a good difference. And we all learn together and achieve maybe better things in the future with these kind of webinars occurring.
Yeah. Partha, are you ready with the results?
Yes, ready.
So we just take one final comment from one of the speaker who is available. Yeah, Ritesh, you are seen. So one final comment about this program from your side.
Sir, I was very stressed preparing what the judge is going to ask. So I was very stressed till the end. But now I am relieved, sir.
That's an honest confession by any presenter. That's the honest confession. Love you, Ritesh. So Partha, over to you.
Yes, just 30 more seconds, please.
30 more seconds. So we invite Parol.
It has not come because it has not come to us. So we know that it is not.
So Parol, are you there? Parol, Kalpana, Asif?
Sir, it was...
Yeah, Asif.
It was really a great experience for me. And then I learned so much from other people. And in fact, it gives us so much new ideas in which you can pursue or think about in a different direction, because different minds think differently. And this is a platform where everyone are involved together. So it was really great.
Great, Asif. So Parol, your comments on this? You have to unmute yourself, Parol.
So it was a very nice session, and it was an honor to be selected from Delhi region. And I thank the scientific committee, and it was a wonderful platform to present in front of such stalwarts.
So it's basically all you speakers, you should be thankful not only to the AIOS Scientific Committee, but first your own state society, because it is the state society which has nominated you for this program. So I think we all give hats up and thumbs up and cheers to the state societies, because they have worked hard to take out the talents from their state and submit the nominations to us. So over to you, Partha.
Yeah. So hidden talents. I don't know. I think we mentioned hidden talents. I think the talent is so exposed. I mean, there's such a wealth of talent that the state societies had the toughest job in selecting just 3 or 4 of what we wanted. And I think Dr. Namrata took the longest to actually name the talents. from Delhi.
North Zone came the last.
There was so much of talent. What to do?
Exactly. So we have everyone there, and the top 3 are going to go up to the finals, and the order of the top 3 is not going to be mentioned. Dr. Mahipal sir is going to declare one, and Dr. Namrata is going to declare the other, and I'm going to declare the third, but nobody knows what is the order of the top. So that is just to prevent the bias. And believe me, everybody was very, very good. All of us, I think all the judges also learned a lot from the presentations, and the whole scientific committee team is overjoyed. So, but before I thank the presenters for presenting wonderful videos and wonderful presentations, thanks to the judges who have taken out time, effort. The judges have gone through the synopsis. I'm sure Santosh has read about PPC as well. So everybody has been well read, and the synopsis were taken into great consideration. And we have now the results. So Mahipal sir, before the results, of course, again, thanks to the team who has worked very hard behind the screen, and Intas has really been very, very supportive and have given this session every time, and they are the sponsors of the session, and also the grand finale is going to be sponsored by them, and it's going to be a lot of greatness, not only on what they are going to sponsor, but also the way they are going to sponsor. So look out for the grand finale, which is going to be really grand. So Mahipal sir, before I ask you to name the first, the other 2 people who are very important, and Mr. Sunil, who has worked very hard with the IT backup, and Mr. Sai Krishnan, who has done the IT backup for the scientific committee, and Pallavi, who is always there to help us in all the work. So thanks to all of you. And now for the results. Mahipal sir.
Thank you very much, Partha, and congratulations once again to you and your team for the excellent work. And I think congratulations to everybody who participated. So as was being said, that we are wanting to get the hidden talent out. So I think the first person that I'm going to announce is not a hidden talent, but it is recognizing the unrecognized. And that is the intranasal cyst in congenital NLDO, recognizing the unrecognized Saurabh Kamal. Congratulations, Saurabh.
Congratulations, Saurabh.
Congratulations, Saurabh.
Thank you, sir. Thank you, all the members. And I also thank the Haryana, obviously Haryana Ophthalmic Society, for putting my name across this wonderful talent search program.
So now, Dr. Namrata.
So I think again, this is not a this is again which was expected. Flat FVP, no PVD, taming, challenging PDR using mini PVD technique, and 10K beveled cutter. Dr. Veer Singh from Punjab.
Thank you, ma'am.
Congratulations, Veer.
Fantastic, Veer.
Again, I would really like to, I just missed their names, but they're the most important people. Punjab Ophthalmic Society, Dr. Karamjeet, Dr. Shakeen, Dr. Ashwini Kalia, for putting me up for this. Thank you.
And Veer, we have seen your video, and you mentioned that in the IRSI video competition, and I think Namrata was also there marking. It was a phenomenal video there itself, there also. Congratulations.
Thank you, sir.
And any guesses for the name that I'm going to give?
No guesses, Partha. Everybody is a winner. So you announce the third name.
Okay. So it is redefining ocular inflammatory diseases using fundus imaging, and Aniruddha Agarwal.
Thank you, sir.
Congratulations, Aniruddha.
Thank you, sir. Thank you to AIOS Scientific Committee and Chandigarh Ophthalmic Society. Thank you so much, sir.
So one from Punjab, one from Chandigarh, and one from Haryana. Good. So before we finish the program, Sonu, I would request you and our scientific committee members to just chip in a few words. You are the moderator, you and me. I think we should you should give your comments and then 1 or 2 comments from our scientific committee members before we conclude.
I think I would like to congratulate each one of the participants for those wonderful presentations that you have brought. And I think Mahipal sir and Dr. Namrata and Partha would agree with me that Indian ophthalmology is at its best. And for all these webinars that we have been doing through the AIOS and through the scientific committee, I think it's phenomenal. And it sometimes makes us feel, are we lagging behind? I mean, we need to really sit back and learn from these young generation, what they're doing, the stuff they're doing. And I think their talent should be recognized. It should be recognized in real practice scenario as well. And that's what I would request our president, who is again a dynamic CEO of one of the amazing, the world's, I mean, I would call it as CFS now stands to, I mean, the most wealthiest of the eye organization anywhere in the world, and they're bound to take one of the companies again, what's there in the market. So, sir, I would really say that you should, what you have been doing is giving opportunities, and that's really worth. So I think this talent should be appreciated. Kudos to all. And thank you all judges. And thank you, Chair, for being with us.
So, Sheila, your comment?
Yeah, very quickly to those, because I've been there where you participate in something, but you don't come in the top 3. So I think that the tip would be to figure out why that happened. It's not that anybody was bad, but maybe they were better. And then see how you or he or she can also get better at doing it. So I think it's just encouragement, and you're the top of your zone anyway.
Parol?
Hi, Amit. So I would congratulate everyone. And I'm rewinding how Dr. Partha brainstormed this idea of talent search from all over the India. I remember that meeting when we had so many things coming up, and, he put forward this so clearly that we have to find out the real talents and the youngsters have to be given a platform. And this is how we started. And we ended with the, the regional North Zone here. And we do have, more exciting things coming for the grand finale, which again, Dr. Partha has really figured out. And, the architecture of the entire thing is so fabulous. So I would say our team is so good together with the great leadership of Dr. Partha Biswas. And this entire, program of the talent search has been a huge success. So thanks to all the participants for making it great, and all the judges and the AIOS Governing Council, who has always been so supportive and been there with, more than 2 hours with us throughout this month. So thank you very much. It's been great. And Dr. Partha, kudos to you and the entire team.
Yeah, I think it has been a fabulous journey trying to unearth the talent from all across the country. It has been a wonderful journey. And the time we started from the West Zone and went to all other zones. And it has been a wonderful thing to come up with these young Turks who are really fascinating. The depth of their knowledge, the type of their presentations, I think it has been learning experience from all of us in team scientific committee. And Dr. Partha has been a wonderful leader and really supported by all in the governing council, our president, dynamic secretary, and it has been wonderful. And I'm very sure you keep your fingers crossed. The type of semi-finals and finals, I think it would be mind-blowing, and it will be icing on the cake. So I request all of the presenters who have won and who have been participants to please encourage all to watch out for this blockbuster performance. It will be really wonderful. Yeah.
Thank you, Dr. Bala. So now I would end this program by thanking Dr. Mahipal, Dr. Namrata, all our esteemed judges and our great speakers and the great scientific team headed by our chairman, Dr. Partha Biswas. So thank you all. Thank you, Intas. Thank you, AIOS office. Thank you, Pallavi. Thank you, everyone. So here we come to the end of the show. Sonu,
thank you.
I conclude over here.
Bye-bye.
Thank you.
Thank you all, and a very good night. Thank you.
Good night. Thank you very much. And congratulations to everyone, all the participants. Bye. Good night.
Nice to see you, ma'am, after such a long time.
Yeah.
Bharti Lavanya ma'am, thank you.
Yeah. And
Yeah, seeing you after such a long
I
time.
was so gracious to say yes